This conference will now be recorded.
Guys, because I'm recording the meeting, so I'm just gonna, 3 hours, 4 hours altogether. Wanna have something. Today, whichever we'll discuss, I want you to apply on the station rather than memorizing it, and that's it. That's communication skills. So one thing that we don't do in communication skills before we start is that we think that we will study communication skills, but we do not apply it on the station. We don't hold these things on the station. Does that make sense? So we always read about ICE, psychosocial, and this and that, but we memorize it and we write it down. That's communication skills. No, you need to make the communication skills blend in the station. So they are all one thing. Clear? So before I start, whichever I write down today, you must make sure you apply it on the station. Not just writing it down, I need to ask about this and ask about this, but then you don't. Okay? With any station, except the acute. Clear? Any station except acute conditions, which means that's 99% of the exam. Because in the exam, you'll have only one acute condition, same man. So any station except the acute station, I must ask 3 things in any station. Guys, wallahi, plenty of marks, inshallah, in this. Plenty of marks. Okay? Plenty of marks. So if you have like some days to just talk about and discuss management and go deep, no, that's plenty of marks. Any station except the cement, I need in the history 3 things. In every station, I need ICE, I need psychosocial, I need red flags. ICE, psychosocial, red flag, any station. Any station, Dr. Karim, before you finish your history, except acute conditions. ICE, psychosocial impact, red flags. Red flags, we know red flags, yeah? Flows. Red flags, flows. So what is red flags? It is the emergency. It is something sinister you're thinking about. So red flags. So ICE, psychosocial, red flags should be everywhere and any station, except acute. Red flags is the flows. Red flags, flows. What is red flags? So in my history, I must exclude Dr. Rada, anything sinister, anything serious. For example, if a patient is coming with rash, I must make sure that this rash is not meningitis. That's red flags. Okay? If a patient is 65 years old, I must make sure that's not cancer. Red flags in any station. Psychosocial, if a patient is coming with a condition, I must make sure the impact of his condition on his life. Daily activity, mobility, work, psychosocial. The impact of his condition on his mood, the impact of his condition on the people around him, the impact of his condition in his life. Am I making any sense? Psychosocial, and that will appear strongly in many scenarios. All joint conditions, all eye conditions, all ear conditions because of dizziness and tinnitus and, psychosocial impact. Okay? If a patient is having, for example, depression, that will impact on people around him. If a, so psychosocial, it is the impact of the condition on the patient life. And ICE. ICE, I-C-E, ICE. ICE, we use it wrong. We use ICE wrong. Okay? Many doctors, yes, we know ICE, but we use it wrong. Number 1, people think ICE, but they don't put it on the structure. Number 2, they use it wrong. What do I mean by wrong? I is idea. I will give you examples now. I is ideas. C, concerns. E, expectation. If I have headache, severe headache in the back of my head, and then you asked me early, for example, what's your main worry? Or if I have chest pain, what's your main worry? Chest pain. What's my main worry? I said to you, doctor, my main worry, which is my main concern. Yeah? Worry and concern is the same. My main concern is MI. My main concern is I'm worried in case it's MI. So can you ask me later on, do you have an idea what's happening? No, because my main concern is MI. So do you have an idea? Is it MI? So that's the idea and the concern, the difference. Because expectation is something else. Expectation, he can be expecting a treatment, he can be expecting a painkiller, he can be expecting a scan, that's the expectation. But I'm comparing between ideas and concern. So the ideas and concern at some station, they could be one thing. If the patient tells you that his concern is a medical condition. So that means that his ideas, what idea means, I'm trying to read his mind. Idea. What? You have an idea what's happening. So if he gives you a concern of condition, so that means it's still his idea. It's the same. However, if I say to you, if you say, what's your main concern? Doctor, my main concern at the moment is that my kids are due to come out of school. Yeah, and I'm in the hospital now. So the idea, is it going to be the same? No, because the idea, it is they have an idea what's happening here about the condition. So do you know now what is the difference between ideas and concern or not? Do you know or not? So ideas and concern could be the same? Yeah, it could be the same. If the patient gives you the concern is his medical condition, but the patient could give you an concern of something else, kids at home, my wife is giving birth, for example, and now he's coming with a medical condition and I should be with her. That's different from, do you have an idea what's happening? Yes, MI, yes, chest pain. But if the patient gives you the concern as a medical condition, that means it's the same as the idea. Guys, clear or? Because sometimes some doctors they ask me, what's your main worry? What's your main concern? I'm thinking could I have heart attack? Then later on, you have an idea what's happening. Heart attack. So it sounds that you don't know even what is ideas and concerns. That's why I explained the difference between them. Yeah. So any station, eyes, psychosocial red flag, and make sure that's what you will forget. Make sure that's in what? In history. Make sure in what? In management, you will bring what? A concern, which we don't do. That's something, communication skills. So make sure whichever concern was given, bring it later. Guys, if you have like 2 weeks before the exam, go on every single station, right? Eyes, psychosocial flags. Eyes, because you forgot to, you know it, by the way, you know these things, but you don't apply it. So in any station, eyes, psychosocial flags. Eyes, psychosocial flags in any station. And make sure that when you come to manage, very, very important to bring his concern later on. Okay? So that's general about any station. But I would like to give you from the start to end 11 points that you should look out for during your station. 11 points, okay? In any station. In any station, Dr. Rada, communication skills will start from the first second I get in, yeah? From the first second I get in the cubicle, that's when the communication skills start. What is the first thing I will see is acknowledge. So once I get in the cubicle, my communication skills will start by, for example, in a case of hyperthyroidism, or in a case of hypothyroidism, the patient should feel hot or cold? Cold. So you get in the cubicle, and everybody, the patient, what he's dressing like 5, 6 layers when you are dressing short sleeves. That's what happens in the cubicle. You get in the cubicle and you are having short sleeves, and they bring someone with many layers. Hypothyroidism station, for example. So I can see you are feeling cold. Acknowledgement. Before anything, confirm identity, I can see you are feeling cold. You see a patient having sunglasses. when he's in the room. There is no sun. I can see you are wearing some sunglasses. Is the light bothering you? You know, that's the first second. So in the first second of immunization, the principles are, when you get in, acknowledge what's happening. When I get in, acknowledge, guys. Maybe you don't do this in the mock that you do, Galaba mocks, but because you sometimes are exhausted, but when you get in the cubicle, if I want you to acknowledge something, I'm a simulator. I'm an actor, yeah? Unless it's not in your mind, you're not gonna pick it up. But if I want you to acknowledge, and you know the word acknowledgement, you will. So acknowledge when you get in, that's first thing. Dr. Hamid, second thing, second advice, because you are going for the exam soon, when the patient talk, do not think of differentials. If the patient is talking, do not think, don't. Wallahi al-Azim, if you don't even think of anything, just let him talk, and you actually listen to him. And you will be shocked that if you let me talk and you listen to me, you will get plenty of questions from the phrase that I said, or from the two sentences, you will. Because the patient will say, well, doctor, I have severe headache, you know, it's bothering me. That's what you're going to say, yeah? It's bothering me, it's been there for 4 days, you know. I really can't sleep, doctor. I really can't go to work. Please help me. Headache, bothering me, I can't sleep, I can't go to work. While you are thinking of, did you injure your head? Any pain in the eye? He gave you a phrase. He gave you a phrase where you have plenty of questions, okay? You have plenty of questions about sleep, questions about work, questions about, you know, psychosocial, questions about many things while you are thinking of, did you injure your head? Yeah, do you have any pain in the eye? Wallahi, if you actively listen to the patient, he will give you the first phrase, the first 2 sentences, he will give you plenty of stuff, Dr. Hamid, to ask about. And once you ask about these things, the ideas will start coming. That's it. I mean, the session started. The problem is the start. So the second principle is, please, when you get in, how can I help you? Forget about the differentials. Please forget. Don't think of differentials. I was one day looking at the door and I will ask about constipation. Okay, straining, sneezing, coughing. That's what we do. No. Go. How can I help? You remember the name and that's it. You go. The patient's holding his eye. Subconjunctival hemorrhage. I can see you are holding your eyes. Everything all right. Start with my station. Yeah? Start with my station. Acknowledge. Well, doctor, I woke up in the morning and, you know, I saw scary. Look, my eyes never looked like this, doctor, before. It's very scary. I'm really worried, doctor. I'm really sorry. I can see you are worried. May I ask, what's your main worry? What do you think you might be having? Yeah? I'm very worried. Well, doctor, I'm suspecting, like, you know, such and such glaucoma. What? So if you listen to the patient, you will have the first 2 minutes comfortably with concerns and everything, and then the differential then will be very minimum because you will just do differentials depending on what he said. So active listening. Active listening. Okay, so acknowledgement, active listening, then eyes, psychosocial, red flags. Then while you are talking to the patient, I said always give reason, always reasoning. For example, I'm talking to the patient about the patient is a female coming with discharge. Yeah, coming with discharge. I will ask sexual history. I want to ask sexual history. But why do I ask sexual history? In the presenting complaint, she said pain while passing urine, discharge from the front passage, and tummy pain. I explored them and everything. Now I want to ask about sexual history. Yeah? Why do you want to ask about sexual history? Why? Because usually when we have patients with discharge and pain while passing urine, we think it might be something related to. Huh? We think it's deep. I'm talking now with the patient language. We think it might be something related to sexual lifestyle. Okay? Tell the patient signpost. Well, Mr. Alex, that's before sexual history. Well, Mr. Why do you want to ask sexual history? Because you fantasize about her having sex, for example? No, because the symptom that she presented with, yeah, led me into the thinking of the importance of sexual history in the station, yeah. Tell her. Well, Alicia, sometimes we have patients with discharge from the front passage and tummy pain and pain while passing urine. We tend to ask them some questions that may lead to us reaching our diagnosis, or that may help us reaching our diagnosis. Is it all right to ask me these questions? Yes, doctor. Well, are you sexually active? Are you? So now she knows that these questions are leading you to your diagnosis, not just for. That's the reasoning. Guys, what I've mentioned, is it easy? It's not easy. In a station, it's natural. If you not in flap 2 exam, wallahi, you come natural. But because we're in the exam, we think of it as an exam. No, what I said today so far is things that should come natural in consultation. My patient is holding the tummy, acknowledge, holding the head, acknowledge, holding, acknowledge. I get in, he start talking, please pay attention to him. Because when he's talking to you, he'll give you very, very, very important stuff. Forget about differential. Then when he finished everything, I found that I need to ask some questions that really maybe not my questions. So tell him, I'm not asking this question for fun. No, no, no. From what you've told me, I'm sorry, exactly the same as when you're giving a provisional diagnosis. When you're giving provisional diagnosis, reasoning, give the patient the reason why you are thinking of this. You came to me, a patient came to me with weight loss, okay? Weight loss, blood in urine, okay? Lumps and bumps in the body, family history of bladder cancer, for example. When I took history from him, I found this thing. I'm giving him provisional diagnosis. I will tell him I'm thinking of bladder cancer, okay? Or I'm suspecting bladder cancer. Somebody else will give him worst and best and worst case scenario. But even when you give him those case scenario, the reasoning. Well, Mr. Andrew, having a blood in urine could be due to many causes. Yeah, you see? Look at my differential now. Plenty of marks. One of them could be urine infection. Yeah. However, listen to after. However, the fact that you've lost weight 10 kilo in the past 2 months, and also the fact that you have family history that cancer run in the family, and the fact that you have lumps and bumps in your body, the fact that I'm giving him the positive, the reason why I will give him the weird. So I'm really worried. I want to exclude anything sinister, like, stop, 2 seconds, sinister is a shot, sinister. What do you mean, doctor? He wants to ask, what do you mean sinister? Give him the chance, like bladder cancer. So please, always give a reason for everything. That's being polite. A reason for everything. That's being polite. Okay? So did you understand these main points before we start? Did you understand these main points of any patient concerns, ideas? Any patient, ask the patient what is his expectations. For example, the doctor is coming to me with headache. Maybe he's expecting CT scan. If I don't ask him, what are you expecting? I wouldn't know. Okay? And when he asked me for CT scan, I will ask him why. Why? What's running in your mind about CT scan? Well, because I'm suspecting brain tumor. Ask the question for brain tumor. Then come later on in the management. Well, Mr. Andrew, you've mentioned to me early on during my consultation that you are concerned about brain tumor and you wanted CT scan. Well, I'm sorry, I cannot do CT scan. No. From the head, brain tumor. If the patient is morning vomiting, weakness, from the history you've given me, I'm not really suspecting that you have these symptoms, and I'm not really suspecting that there's something serious going on. Did you understand the way of talking to the patient? But we know, we've asked the symptoms are negative, but we don't tell the patient. We just say, well, I'm sorry, from the history you've given me, like, I mean, I don't think CT scan is indicated, and that's it. Why? Make me understand. Give me a reason. Give me a reason for saying this. Okay, so guys, did you write these points? ICE, psychosocial, red flags, reasoning. Well, reasoning is something, if you are nice, you're going to give a reason. I'm late, and that's it. Guys, I'm sorry I'm late because last night I was at home, like I stayed up late and I did this. I'm sorry, you know. So reason. Okay. Now the first station is breaking bad news. Breaking bad news stations. So that's the first kind of scenarios, breaking bad news scenarios. Dr. Mahmoud, you will have a breaking bad news scenario. You must have Dr. Hamid break. You must. You cannot just have a break. Okay. Breaking bad news. I need to take some history. I need to give a diagnosis, and I need to manage. Breaking bad news. So the first scenarios are breaking bad news stations. Dr. Hamid, I must take history. I must give what? Provisional diagnosis. It's not actually provisional. It is in brackets what? The what? But I'm talking you with the language of my structure. Any station must have, and must have management. Any breaking bad news the same. I will have history. I will give provisional diagnosis breaking bad news. I must manage. So, but the only thing with breaking bad news that my history should be no one word better, not just short. Relevant. Has the video stopped? Okay. But the only thing that my history is going to be relevant. Relevant history. Relevant history means شو؟ هو تمام. So relevant history means that I don't want to talk about medical conditions and this and no. A patient is coming subarachnoid hemorrhage. Subarachnoid hemorrhage. My history, tell me about the headache that your husband and your partner have, high blood pressure, cholesterol, diabetes, polycystic kidney, bleeding disorder, blood thinner, smoking. Family history or something like that. That's it. Why? Because the condition breaking bad news will be confirmed. It is CT scan done, bleeding in the brain. So relevant history. So in the history it will be relevant. Plus, if you don't do it, you will be deducted plenty of marks. This is the ITS here, support. So because I will give her bad news, do you know you're gonna give her bad news? You know. Yeah, we know. So because we know that we're gonna give her what? We must make sure that we know about support. We know about who lives with you at home. Is anyone here with you in the hospital? Anybody's living with you at home? Any relative nearby? That's in that history. Why in the history? Because everybody, when they give Dr. Karim breaking bad news, they say, would you like me to call anyone? As a general question. But me, no. Me, because I already asked about. So whichever she tells me, I'll bring it. Would you like me to call you? You've mentioned to me that your son lives at home with you. Would you like me to call him? It's better than would you like me to call anyone? No. So in the history, please, 2 words, relevant question and support. And in fact, what are the relevant questions I need to ask? The risk factors. Why? Because later on, so in the relevant questions, you ask only the risk factor, the causes. Because later on, Dr. Hamid will say to me, why this happened? well, you mentioned to me that there's family history of this, and he had headache and bleeding and polycystic kidney, and so the history will be risk factor support system. Then, when you go to breaking bad news, how to break the bad news? When you break the bad news, guys, don't be like robotic. Robotic means first warning shot. You have an idea what's happening. No. Second warning shot. And they think, what could be the second warning? I forgot. No, guys, break the bad news, but don't give her, yeah, on her face, everything all together. Doctor, if I failed my exam, and you want to tell me I failed my exam, you're not going to say to me, how you failed your exam? Well, Muhammad, you know, sometimes things happen, but for a reason.
Sometimes we take lessons.
Okay, things happen for a reason. Yeah, sometimes. Look at me, for example. If I didn't come to UK and I expired my visa and I overstayed in UK, I wouldn't, you know, do this, I wouldn't do that. Okay. Well, Muhammad, I'm sorry. I don't have good news for you. Well, you know, so break it your own way. That's my point. Don't think of like, I have to have this phrase and this phrase and this phrase. No, no, no. Breaking bad news, Dr. Karim, do it your own way. Now I'm telling you, do it your own way, but don't give him the news. My own way is, that's it. I finish this, I'm going to the breaking bad news. Well, Doctor, guys, you see what I did now? What did I do? Well, Dr. Walid, do you have an idea what's happening here?
No, not yet.
Well, I'm afraid I don't have good news for you. Well, we've done a CT scan, as I mentioned, and I'm sorry, it showed some bleeding in the brain. That's a breaking bad news. I did not think of anything, of any steps, but I showed him that I don't know how to start. I'm not happy with saying it. But if you memorize phrases and you want to tell it, you will look robotic. You will look that, no. Guys, please think of this person. There are something bad happening. Tell him your own way. Doctor, okay? Your own way. In a way that really you are telling someone that his dad passed away. You are telling someone that, you know, something like this. Clear? That's the breaking bad news. Management, we forget. Dr. Hamid, management, we forget. What do you mean? In the most important station, intracranial hemorrhage, yeah? It is written that the management will be palliative care, yeah? But we always forget to give our time to the 2 minutes of what's gonna happen. Palliative care itself is a breaking bad news, yeah? Let him ask you questions, explain to him what palliative care is. So give time, because all of us forget about the management. We think that the end of the station is, no, there is a part of it. What's going to happen, doctor? Doctor, what do you think is going to happen? Doctor, is he going to be okay? Doctor, how would you manage him? So that's a big chunk that we forget about, which is the management, which, don't worry, it will be written in the question, because this station is confirmed, something confirmed. Go and break the bad news, and always the management is written for you to give it to us. Clear? That's clear. Breaking bad news. Very important. Risk factor, support. Breaking bad news, give warning. Warning, the best warning is, do you have an idea what's happening? Why? Because if he's expecting that, if he said, well, doctor, is he gonna die? Don't say, if the question said that he's gonna die, don't say, well, no. Or don't be scared. Because if he said to you, is he gonna die? And the question said he is going to die, what's your answer? Well, I'm sorry. Yeah, you understand? Like, you know, I'm afraid. You know, well, you understand? Don't be scared, because that happens. When you come to break the bad news and the patient relative said, is he gonna die? You always get worried of answering and say, well, I'm sorry. Yes, I'm really sorry. You understand? So if I'm telling you, Do you need to break bad news? Do you need to go for layers? Like, huh? No, because I'm giving you. I'm ready, mentally ready. Okay?
But it is fine to say it is very difficult to confirm when he is going to die. It's very difficult.
They ask you, when is he going to die? You don't know. Yeah. Okay? If you
Okay, sorry. Maybe this is a question. If you are,
you see that, and when you do the recorded course, people say, why do people ask questions? Because we can't handle. We have to ask. Yeah, carry on. Ask.
we can leave it to that.
يا عم اوكي خلاص انت ask الباب
You're being asked, that could you keep my dad alive for a week or sometimes?
Well, can you keep him alive for a week?
For a week or so.
Can you?
No.
You understand? If my dad is in the stage palliative care, in the stage of cancer, and the relative is asking me, can you keep him for a week? Can you? Can you guarantee? But can he actually live for a week without us, like, Yes, he can. So, well, it's something really that we cannot, do for you, but let's hope for the best. Let's hope he's gonna make it for until you have your baby. But I cannot guarantee, because if I can, I will get everybody else's life. Am I making any sense? So don't be scared to say where we can, where we cannot guarantee. Okay, yeah. So in the support system, how do you ask who's at home, who's living with you, anybody nearby, relative nearby? The support system is the most important part in the breaking the bad news. Guys, there's something very important. Give the patient time to absorb, which we don't do. We always say, do you have anything else happening? No, doctor. Well, I'm afraid. I have bad news for you. I'd like to tell you about it. Yes, doctor. So they will mark you very low in communication skills, and you can fill the station if information is good, which means be what? Be slow. Be slow. What is the meaning of slow? Delivering the news. Give the patient, guys, time. Don't worry about the time, please. Don't worry about the 8 minutes. Your job is not to go and say, well, I'm afraid I have bad news for you. Do you have an idea? Well, he's gonna die. No. Your job is giving him his time, even if your time will end. Give the time. If the patient is crying, don't just seem in a rush for him to stop, for you to start. You understand? No. Pause. Don't worry. Pause. If the patient in front of me seems shocked and they start, oh my God. Don't just, okay, everything will be okay. I'm here with you. While he's absorbing the shock you are, don't talk. If the patient gives you these signs of shock and he's not, please don't talk. Let him absorb. Communication skills will go low. Leave him. Obviously, back home we don't do this, but here no, they give you space. Give him his space. Okay? If a patient is refusing something, a patient is coming to you and is not. Yeah, thank you. If a patient is refusing something, a patient is coming to you and from the first second he is refusing something. Wallahi, scenario in the exam. A patient is refusing. If a patient is refusing something, what is the most important thing that I need to establish if a patient is refusing something?
Why?
No. If a patient is refusing a treatment, I'm not going to bring you for why. I think I'm going to go for something extra. Yeah? You understand? Why we don't have a day for it? If a patient is refusing something, like I don't want to stay at hospital, I don't want to get treatment, I don't want to be admitted, I don't want this operation. The first thing that you need before you leave the cubicle to establish is he of a sound mind or not? What do you mean? If I'm talking to a patient who has mental problems, who is not competent, a patient who has dementia, A patient who is confused and he is refusing something. Can he refuse something? A patient who is confused, refusing admission. Can he refuse admission? A patient who has dementia, refusing surgery, for example. Can he refuse surgery? No, that's my concept. Before I give you the right, does the patient have the right to refuse?
Yes.
Yes, he does, except if he's not of a sound age, or if he's not of a sound mind, if he's not competent, if he's not of a sound mind. If the patient doesn't understand what's happening, Dr. Moba, how do we know that he's of a sound mind or not? How? From the conversation. So when a patient say, well, I want to go home, doctor, in the back of my mind, I want to make sure he's of a sound mind. He knows what's happening. I will start my station normally. Why do you want to go home? Well, doctor, because I have my kids at home. Okay. Well, is there anybody there? Anybody nearby? Well, yes, doctor, there are some families there. Can they look after the kids? Well, yeah, why don't you tell them? Well, we need to keep you in the hospital. Do you know why? Why, doctor? Because you have low blood sugar. Low blood sugar can lead to sudden death. You need to be kept in the hospital. Well, okay, so if I actually leave, I may die. Yes. You mentioned you are diabetic. Okay, so we need to keep you in the hospital to give you some fluids. All right. So, do you know why now you need to be kept in the hospital? Yeah, because you said it's life-threatening. No, doctor, I want to stay. So the fact that the patient is talking, retaining, you are giving him information, he understands, you are talking to him, things back and forth, you can see. So the competence is something that Dr. Hamid, you will know from the way the consultation is going. If you are talking to someone who is mentally, there's a problem mentally, would you not know? Would you not know? No, seriously, would you not know if I'm talking to someone who's mentally not okay? Would you know or not? Yes. So if you, at any scenario, because I'm expecting such scenario, they bring you a patient, I want to go home, but he's not the patient that you used to. He's not the one that, no. He's someone not of a sound mind. Will you admit him? Yes. By force? Yes. Mental health act. If they bring you a patient, I want to go home. This is the start. But he doesn't know where he is. He doesn't know how to confirm his name, his date of birth. He's confused. He doesn't know what's happening. Would you admit him? Yes. So that's one thing, Dr. Hamid, in a refusal structure patient, in a refusal patient, a patient who's refusing something, my thing is, we know, I will ask him, why are you refusing this? He will give me a reason. I will try to address the reason, and he's still refusing. I will move on to the next. Do you know the risk of what? Leaving the hospital that will happen. Do you know the benefits of staying in the hospital? But Dr. Omar, I must, during my station, make sure that this patient of a sound mind, he can retain information, he can give me. When I ask him, he knows what's happening. Then this structure will be applied, but if he doesn't know what's happening, I will not be able to apply this structure because I will admit him by force. Okay? And after, when you're talking to a patient, there is a misconception here that we think that in order to pass, we must convince him to stay. And to pass, he has to stay in the hospital. I have to convince him. No. Okay? So if he's not convinced, Dr. Mahmoud, it's okay, he's not convinced. But what to do if he's not convinced? Okay? What else? Sorry? Yes, you can give him alternative. So that's something else to add to your mind. Huh? Something else to add. So something to add in the refusal structure. If a patient is refusing something, I must make sure he is he's competent. He knows what's happening. He knows the risks. He knows the benefits. And he's talking with me during the consultation. Then does he have the right to leave? Yes. However, before he leaves, make sure safety net dash alternative. What is the meaning of safety net dash alternative? Safety net dash alternative means I have something else to offer. Yeah, for example, you can ring 999. If you have this, you can do something alternative for his condition, for his situation. A patient who is infective endocarditis and she wants to go home, and that's it. You will smoke in the hospital. No, you will smoke in my office. Stay in the hospital. You know, the patient doesn't. The patient wants to go home. That's it. So before she leaves, I told her about the risk, the benefit, everything. I must at the end give her alternative. Anytime you feel severe chest pain, anytime you feel they are about to collapse or they are about to faint or you have very high fever, please ring 999. Do you have anybody at home? Yes, I have my daughter. I have my sister. How old is your daughter? She's 16. She's 17. Please let her know at any time in the morning, for example. Yeah, in the morning at any time. You don't wake up or you feel very lethargic. You cannot let her ring 999. You understand? You are giving her alternative. So please, before you end the station, even though the patient will go, and please, the conception of I have to convince him. If I don't convince him, I fail. No. I can bring you a scenario. He's not going to stay. He's refusing. He will go. Risk. He will go. Benefits. He will go. Address concern. He will go. It's fine. Go. But before you go, you should know that if you feel 1, 2, 3, do this. You should know that if you feel chest pain, take this. You understand? You should know that if you are short of breath, take this. That's the alternative. Okay? So that's if the patient doesn't want to stay in the hospital. And something else will sound nice. If the patient is giving you, Dr. Mahmoud, a reason. Well, doctor, I want to go home because of my daughter's birthday. Answer me. Aywa, did you get this? Did you know what I said? What did he say? Yeah. Yeah. Yes. Yes, carry on. Doctor, I want to go home. I don't want to stay in the hospital. Hypoglycemia. I don't want to stay in the hospital, doctor. I want to go home because it's my daughter's birthday, doctor. I have to attend my daughter's birthday.
Well, okay, so could you try to go ahead just to make it getting better because you need to stay today with us. And I know it's difficult to not attending this day.
I want this sentence after her birthday.
Yeah.
That's it.
I can see that you are killing part of
Yes, yes. I want this sentence, not, no. You can call her. That's addressing the concern.
Okay.
But the reflection is, oh, happy birthday. Now I understand why I want to go home. It is a valid concern that makes me, yes, I have, yes, I'm not stupid, I'm not dumb. Yeah, he's agreeing with me that it's a valid concern. Okay. But, say what you want. What? But you can call her, but you can make a video call, but you can order her present online while you are in the hospital and make a video call. You understand? Whatever concern you're going to address. But happy birthday, I can see why you are concerned. Now I know why you want to go home. Well, it's a valid concern that you want to go home. Even though he's not going to go, I don't want him to go, but acknowledge the importance of his concern. Acknowledge what? The importance of his. By the way, if you are in the same situation, you will want somebody to acknowledge the importance of your worry. Think about it. Seriously, you will want someone, guided psychological, you will want someone to say, yes, you are right. Yes, you are right. Yes, I can see it's very important to concern, but okay? So acknowledgement, the importance of the concern is very important. Make sure you always safety net or you always give alternative. Okay? Guys, are you tired? Is it boring?
No.
It's not yet. It's thing that's very important. Wallahi, very important. It's some doctors fail because of 0.01. 0.07. A phrase will get you this 0 point something. Okay? And the way you reflect, that's the word of reflection. Dr. Mahmoud, when I said to him, it's my daughter's birthday, I tell you the word reflect. Reflect. Okay, we'll reflect. We'll reflect. What is reflect? My daughter's birthday. What?
Congratulations on your daughter's birthday.
Well, happy birthday to your daughter. Okay? You understand? How old is she? How old is she gonna be? She's gonna be 5. Well, I'm really happy. I'm really glad. Well, now I understand why you're concerned. Well, you have a valid concern. Well, that's the communication skills. Okay? 4 marks. As much as management. So 4 marks management, 4 marks communication skills. But the communication skills, the good communication skills, distract me myself in the mock. In the mock, I get distracted myself with the doctor who have, any doctors, when they have good communication skills, they distract the examiner. Seriously, you could say nonsense about management, and your management is not really good, but you look good, you're talking good, you're talking nice, you're interacting good and reflecting, and wallah, many people. Doctor, I go 140, and management, they just like, you understand? I'm not saying management is not important, but you get distracted. As an examiner, as a mock examiner, when I have Carlos in the station, you know Carlos, when I get distracted. Well, I'm gonna give you oxygen, right? You know, look, I know, right? Don't worry, right? You will be, you know, I'm here, right? You know, like, understand? And I lose it. And then at the end, while I'm assessing him, I find that he forgot all the investigations, but I pass him. You understand? He did not give such management, but he honestly will pass him. Okay? Like one of the doctors, I gave him a station, hypoglycemia, and the reason I was fasting. I was fasting. And I had my insulin, even though I was fasting. Then I collapsed. He was managing me, and he said to me, I'm really sorry. I'm sorry. You'll have to break your fast. And he said it like this. Seriously, Wallah al-Azim. He said it like this. Well, I'm really sorry. You've mentioned to me that you are fasting, and it's the holy month, it's Ramadan. I'm sorry. You will have to break your fast. I'm going to have to give you something to eat. I'm going to have to give you some fluid. I'm really sorry about that. I know it's important, but I'm sorry. Same man. That's marks down the train. You understand? Did he do something right? Yeah. I'm fasting. I'm fasting still. I'm hypoglycemia. And they said to me, sorry, to break your fast. I'm sorry, you have to break your fast. Is it right or wrong?
That's right.
Yes. Okay. We will talk about the next scenario of an angry patient, which is again very common in the exam, and how to interact. I'm sitting. This is another scenario, yeah? Guys, we just breaking bad news, refusing, yeah? If I'm angry and Dr. Karim sitting in front of me, which will happen in the exam, 100%. I've done it many times. If a patient, angry patient, scenario, if a patient is angry, the patient, while I was talking to him, he stood, standing. What should you do? Stand. If a patient, while he's angry, coming close to me, what should you do? Keep distance. Okay, that's logic. That's logic. Some doctors in an angry patient, they come close to me to show me sympathy. Well, I'm sorry, I'm angry. No, don't come close to me. So please, an angry patient, if a patient is standing, don't be sitting. Your eyes has to be in the same level. If a patient is sitting, you are sitting. What if you start the scenario and the patient is standing shouting? Confirm identity. And then ask him to calm down. Sit down. Don't say calm down, it's wrong. Calm down. No. Ask him to sit down. So, Mr. Karim, I can see you're upset. Well, can you please, if you don't mind, can you have a seat so we can move this situation further? Well, I'm here to help you. I'm here to address your concern. But is it all right if we have a seat to be able to move this situation further? You understand? You see that these phrases like, it's okay if you have a seat so we can move the situation further. So please don't forget how the patient is angry, standing, stand, sitting, sit, go close, go far. It is a scenario in the exam, angry patient. Don't forget, Dr. Hamid, that with an angry patient, you must acknowledge he's upset. Tell him, I can see you're upset. Well, your concern is valid. Doctor, my son, well, I totally understand. I can't even imagine what I must be going through. What am I doing now? You have the right to be angry. That's what I'm saying. Because if you tell me I have the right to be angry, that will calm me down. You have the right to be angry, but is it okay if we have a chat about what happened in order to move the situation, in order to address your concern? Now I'm starting to take. But what did I say in this phrase? Why do I want to have a chat? To address your concern. No. So, is it okay if I have a chat? Why? To address you. So I'm giving him a reason. A reason. Guys, words. Because a patient who's angry, does he want to talk? Does he want to give you history? He wants you to solve my. So that's why I'm telling you, let's have a chat to understand what happened better in order to address your concern. So please, an angry patient, acknowledge the anger. I can see you're upset. Please, it's your right. You have the right to be upset. A patient is giving you my son, my daughter, I can see where you come. Acknowledge. Give him the right that it's your right to be angry. Then, Dr. Hamid, this is the first 1 minute. It's okay if I have a chat. Can you please sit down so we can move further? When I can see you're upset, well, you have the right to be upset. You totally have the right. I totally understand where you're coming from. But is it all right if we have a chat so I establish what happened to address your concern? I'm here to make you happy. I'm here to address your concern. Guys, this is the start. Forget about what's going to happen, because if this patient, if this relative is calm, the station's finished. Your job is to calm him down, yeah? It's to calm him down, but I'm here to help. Imagine if I'm angry and someone said to me, you don't have the right to be angry. Well, what's going to happen? No, seriously. Imagine if I'm angry and someone said, yes, you are right. You have the right to be angry. But my job is here to address your concerns and resolve this situation. Is it all right if we have a chat to make sure that everything is okay? I will address your concern. What's going to happen? Guys, please, angry, patient, acknowledge. Always think further. Okay, let's have a chat to address the concern. I'm here to help you. I'm here to address your concern. You have the right to be upset. And if it was a situation of an angry mother whose son was given medication who had allergy to, if it was me, if it was my son, I would feel the same. Or how would you feel if the doctor said to you, well, you totally have the right. If it was my son, I'm sure I'll feel the same. What's going to happen to you? Would that calm you down?
Yes.
So please, that's the station. That's how you approach the patient. So eye level, be at the same level. The distance, he comes to close, go back. Acknowledge his anger. Tell him, I can see you are upset. Say to him, it's your right to be upset. Always look further. Always what? What's the meaning of looking further? Forward. Let's move from this situation and try to solve your problem. That's going forward. Okay? Can you ever, guys, I'm giving you answers for questions will be asked. Can you ever blame a colleague if you were not there? That's an answer. You cannot say, well, I'm so sorry for my colleague that he was racist to you. The patient, one of the cases, saying your colleague was racist to me and my son because my son has cerebral palsy. Well, I'm sorry. I'm really sorry that he was racist to you and your son. No. Well, I'm really sorry if you are feeling that way. Well, I'm really sorry if you felt that way. Well, I'm sorry I wasn't there, but I will try to talk to my colleague and get to the bottom of this. But my main concern is your son and the X-ray that you need for him. Let's move further, make sure that your son is okay. Then I will get to the bottom of this and talk to my colleague and see what happened. Do you understand what I mentioned? What I did in this situation now?
Smooth transition.
Sorry?
Smooth transition.
I moved and I was not there. I'm sorry I was not there. I'm sorry if you felt that way. I'm sorry if you felt that way. My main concern is your son. Let's move further. We'll order the X-ray. I will make sure I'll have a chat with you if he needs it. I will definitely order it for him. And later we can talk about this issue and I can talk to my colleague and see what happened. Please do not say sorry about something that you weren't there. Do not say sorry about your colleague when you don't know what happened. Am I making any sense? Because if you said sorry about my colleague, that give him the right that your colleague was wrong. That's it. You cannot just come out. If I said sorry about what he did to you and I wasn't there, that's it. Okay? So do not give excuses. Dr. Hamid, while I'm talking to a patient, by mistake, I might give, well, I'm really sorry, I'm a junior doctor and I couldn't read the X-ray. That's wrong. There is no excuse for reading the X-ray. Well, I'm really sorry that I did not take history properly. So do not give excuse. Well, I'm really sorry about my colleague, what he did because he was busy. That's a concept. Don't give excuse for a patient complaining. Don't give excuse that this happened because of this. There is no excuse. Well, how can I say it? How can I say it? Because
this shouldn't be happening, but now we need to get more.
It's just a phrase of the patient telling me something, and I missed the X-ray. I missed the foreign body. I missed it because I'm a junior doctor. Is it an excuse that I'm a junior doctor? No. But how can I say it? I want to tell you, well, I'm really sorry, Karim. This shouldn't be happening, actually. There is no excuse for this. However, I'm not that experienced in reading X-rays. What did I say first? This shouldn't be happening. There is no excuse. However, I'm not that good, and I'll try my best to read, to have courses in X-rays. So that means don't give excuse. But I could say to Karim, well, Karim, I'm a junior doctor. I couldn't read it. What about my son? You are a junior doctor, you couldn't read it. You're going to kill my son? Yes? So don't give excuse. Acknowledge the anger. Tell him you have the right to be angry. But let's move further. I'm here to address your concern. Well, what happened shouldn't be happening. But let's move further. Well, I'm sorry if you felt that way. I wasn't there. I will try to talk to my colleague in order to get to the bottom of this. Guys, I am giving you answers for situations. Yeah, I hope you understand. You cannot memorize it. You just have to understand how you're going to do. If he gives you, what are you going to say? If he's angry, yes, you are angry. Yes, you have the right. Don't ever say to him, no, no, you don't have the, you have the right. If I was you, I would feel the same. But let's move further. My main concern is this. And that's when, Dr. Hamid, you will be able easily to get history. You will get history easy if you approach him that way. Okay. Angry patient and angry relative is the same. Yeah. Angry patient and angry relative is the same situation. Okay. if a question doesn't say clear, very important. If a question, Dr. Mahmoud, doesn't say clear. Last week, I gave them the mock dementia. Who had the dementia case with me last week? Dementia. Talk to mother. Talk to son, Mr. Logan. Are you? Anybody had this session with me in the mock? Anyway, everybody told me what's happening. Everybody told me what's happening. What's happening here, Kunde? Everything. But nobody asked for consent. I did not mention consent in the question. So always don't be scared. Am I going to be too controlative? Yes. Consent is taken, written in the question? Yes. What is not taken? It's not mentioned. Don't worry. When you get in and you ask, she will tell you, I have a consent. Because if she said no, thank you, you're going to wait till the 8 minutes. So she does have a consent about it. You should ask. Easy, simple, no offense. No offense, Dr. Hamid. No offense. I'm really sorry, Alicia. I'm here to talk to you about your mom. Can you confirm your full name and date of birth? Yes, that's that. Okay, do you have a consent for me? Yes, I have. Yes, yeah. One of the doctors once, what if she's lying? It's not my fault. Because it's a station, you know, what if she's lying? You understand? So don't think of it like this. Dr. Samira, if I say, do you have a consent? She said yes. She has a consent. So last mock, Dr. Hamid, something very funny happened. And this will happen with you guys. Very important. Very important, very important, very important. The question said, do we all know about dementia? Yes. Have we all memorized this case? Yes. We know the case. Last week, the question said, Mrs. something, 76 years old, she has advanced dementia. Her son, Mr. Logan, is coming to the GP clinic to talk about his mom. Talk to him, address his concerns. How can I help you? Doctor, I'm coming to talk about my mom's condition. Nobody asked about consent. Okay, I said, Mesh. Don't put them off. Okay, carry on. But if they asked, I would say, the question didn't say any. The question I did not write, consent was taken, nothing. Not even one person asked me, Mr. Logan, do you have a consent? So we can, yeah, no problem. They're not going to be offended. Then, my main concern with eating. She doesn't feel well. That was my main. So how can I help you, doctor? I'm concerned about my mom because she doesn't eat well. So what should be the whole station about? Guys, by the way, some of you might be thinking now, what are you talking about now? What should be the whole station about, doctor? Feeding. Feeding only. So the main concern that I had was she doesn't eat well. How should you approach the station?
What do you mean?
What do you mean she doesn't eat well? When did you notice she doesn't eat well? For how long have she been having this problem? What food do you give her? What? So I'm doing data gathering about what? Feeding. Has she lost weight? Do you think she lost appetite? Do you think she could be upset? Do you think you could be giving her the food that she doesn't like? What is this? Data gathering. Data gathering. But look at my data gathering. Feeding. But everybody else, well, I'm really sorry about that. Do you know what dementia is? Dementia is a blah, blah, blah. Okay. Do you know what will happen? Yeah. Do you know how you manage dementia? Yes, yes. Have you heard about hospice? Yes, yes. And you know what? And the whole dementia case, the one that they read, they told me all knowledge. But feeding was not mentioned till the end of the station. And then later on, they said, well, you know, there are some procedures, the NGT guys, and they forgot totally, Dr. Hamid, that why am I here for? Huh? Feeding. Only feeding. The station is only about feeding. Guys, it is funny that you get carried on your own way, and you forgot at the end that it was about feeding. He's coming for feeding. He's not coming to you know. No, he's coming for feeding, and then you can ask about feeding in details. Okay. When I asked them, when I told them my mom is not feeding well, everybody started asking about medical condition, medication, allergy, family history. Do you know what dementia is? Do you know? And they literally didn't know anything about dementia. And they even said to me, well, it's because of dementia. Dementia can cause this. Where's the data gathering here? My mother is dementia. She doesn't eat well. What's your data gathering? Feeding. What do you mean? She's not eating well. For how long? I noticed it 2 months ago. Increasing or not? What could be the cause, guys, for not eating well? A patient is not eating well. She's dementia, but she's not eating well. What could be the cause? Only dementia? Could it be the food? Could it be the mood? Could it be that she's feverish? She's having a medical condition for which she's feverish, so she, you know, many causes. So please, Dr. Kareem, when people come out of the station, they have this common saying, I did everything, but I got 111. Why did you get 111? Because in the data gathering, yeah, brother, you're feeding data gathering with just 1 mark out of the 4 data gathering. And yeah, brother, when you managed everything, but talking about feeding was only, you understand me? Yes, I gave you 111. Yes, you said everything, but you said everything about dementia, about dementia, medical condition, you know, incontinence, urine, you know, bowel, what was the feeding? How much was it mentioned in the station? It was mentioned 25% of what you should be talking about. In data gathering, you only asked about feeding, 25% of what you understand. That's so important. So that will bring you back to Dr. Hamid. Any counseling station, do not forget why is he here for. Do not forget your data gathering is about his station. Inflation 4 minutes, 5 minutes, but you get full mark. Station, you did everything, you finished it, but you failed because yes, I told them everything about dementia, but I did not mention enough about where is he here from. He's actually here in front of me. He's called for feeding. That's one thing. Just have it كده, because that day I've heard 8 doctors, and the 8 doctors did what I said. They talked about dementia, but they did not talk about feeding. Okay? Patient is complaining about something. If a patient is complaining about something, that's an easy approach. I'm coming to you in the clinic, okay, and or in the hospital, and I am complaining that my son is covered in poo. He's been admitted for a while, and he's in the hospital covered in poo. This is my complaint. That's the start of the station. How do you approach me? I'm complaining if my son is covered in poo. Anybody can start the first 1 minute with me. How can I help you? Doctor, I'm very angry. Doctor, I came to the hospital and my son has been admitted here and is covered in poo and vomit all day. This is not acceptable. How would you react?
I'm really sorry about the situation. I'll call one of the nurses to sort this out. And I'll give furthermore what's happened. Can you talk now?
بس مش على بعض بقى كل مرة لوحده.
Yeah.
You see what she did? I'm really sorry. I will talk to the nurse. You understand? Break it down. So she's trying to, yeah, but I'm gonna break it down. Well, I'm really sorry. I can see you are upset. I'm really sorry about this. I know now why you are upset. Huh? Give her. Yeah, I have the right. If it was my son, I would feel the same. It's acceptable to be upset, but let's move forward. How's he now? Guys, it's the same what I said. You see? Let's move Okay, don't be stuck by how. Okay, how's he now? He's covered. I will make sure he will be cleaned now. But is it okay to move further to know what happened? Yes. History taking about when did you notice? So what is my history taking here? About what? The incident. Which is the main complaint, which is the main concern. So I will come back again to my data gathering hole will be built on the complaint. Everybody, Dr. Karim, leave the complaint and we go to other things. No. She's here because her son is covered in vomit and poo. She's upset. I can see you're upset. You have the right to be upset. It's acceptable to be upset. If it was me, I would feel the same. How's he now? We're gonna make sure he's clean. But let's move further to address your concern and make sure this will not. When did you notice? How did you notice? How many times did you notice this? So I'm trying to do data about the main concern. What is the main concern? So everybody else will start talking about nonsense topics, and will forget actually why is she here for? For what? For the abuse of the child. So focus on it. Data gathering about it. Address it. How to prevent it. But before that, the approach is, I can see you have the right. I can totally understand. If it was me, I'll feel the same. Totally acceptable. We'll clean him. Let's move further. What is further? Tell me what happens to prevent it happening again. When, since, when, how, this, and then go back to the management. Guys, is it fitting? Guys, this is the. You understand? This is the entrance. That's the difficult bit. The rest is easy. The history, because as long as she is okay to talk, station is okay, finish, done. But make sure when you start talking, what will you be talking about? Please, what I am here for, not others. Okay? Okay. Alcohol stations. Anybody who had alcohol stations, their main concern, the patient doesn't talk again. So guys, are you able now to, the patient is angry, the patient is upset, how to calm him down and don't worry, let's move further. My main concern is your son. I can see you are upset. You have the right to be upset, but the main concern, let's move further. And what do you know now? What is your data gathering will be? Not data gathering for no. His problem. Now alcohol patients. Everybody who had alcohol stations always say, my problem is that the patient doesn't want to talk. The patient doesn't want to open. How do I let the patient in an alcohol station open? How do I let the patient, Dr. Karim, in a smoking station open? How do I let the patient in a station where a visible diet open? Dr. Ward, the problem is how to let him talk. The best trick, when you see at the door, I'm talking about alcohol, ignore alcohol. When you see at the door, I'm coming to talk about smoking, ignore, forget about it. Because once you mention it, he will be angry. I will give you the approach for the three. The alcohol, the smoking, the diet. Okay? He will be angry. So my approach will be, that's the question. Mr. Joshua, in the hospital for angioplasty, for what? PCI, whatever. Your consultant asked you to talk to him about smoking. Mrs. Whatever, she's been admitted in the hospital for liver problem, yeah, ascites, whatever. Your consultant asked you to talk to her about alcohol. Well, I'm here to talk about smoking. How much should you smoke? Again, you come to talk about smoking. I hate this hospital. No. Well, I'm here to talk about alcohol. No, forget. So my trick will be, Dr. Karim, I will start by the relationship or the causes of her being in the hospital and scaring her of her condition. Forget about alcohol. Guys, it's a trick. In all the cases, anything, exercise. Can I give you another scenario? Recent scenario as well. 75 years old, MI diagnosed, managed, he's refusing to walk. Well, it's boring now. Now they're getting bored. Okay. 65 years old, MI, managed, refusing to what? Dr. Mahmoud, all the same. Hello, Mr. Ward. On your name, that's it. Future now 5-6 years in advance. Ward Mahmoud Hamid. Hello, Mr. Ward. Yes. I can see from my note that you are due for procedure. Procedure. Yeah? Angioplasty, for example. Or I can see from my note that you've been admitted for MI. Heart attack. Yes, doctor. Yeah. Well, I'm really sorry about the terrible experience that you had. Do you know what heart attack is? So now I'm educating him about his. Guys, it's all the same, yeah? Do you know what ascites is, for example, the alcohol case? Well, I can see from my note that I are due for a procedure. Do you know why you have this procedure? Assess knowledge. Oh, well, yes, doctor, yeah, I know. Because I had heart attack. Well, I'm sorry. It must be terrible. It must be that you experienced terrible pain. Yeah, doctor, yes. Well, I'm really sorry. Well, do you know what heart attack is? Well, no, doctor. Well, heart attack is decreasing the blood supply that's going to the heart. Sometimes it's actually blockage of the blood supply. Well, it is terrible experience to have because patients who have severe pain. Oh, yeah, I did, doctor. I did have severe pain, but I'm not in pain now. I'm fine now. This condition is life-threatening, I'm afraid. Would you like me to tell you about the causes of heart attack so we prevent this from happening? Oh, yeah. Because you told them life-threatening. You told them? Well, yes. Well, some causes, we can actually work on them. It's lifestyle, like diet, like exercise, like smoking or alcohol. If we do work in this, there's a high chance of decreasing the expectation of the chance of you having this terrible pain. Terrible pain. You see, I'm always life-threatening, terrible pain. Yeah, doctor. Yeah. So it's alright if we have a chat, small chat, if it's okay, and we see where we go. Yes, doctor. Yes. Then start talking about smoking. Ask about smoking and go smoking station. But now when you start asking about the smoking, he knows that smoking is the reason why you are discussing it with him, because it's the reason why for the heart attack. It's not just because you want to talk to me, it's because you want to decrease the risk of me dying, life-threatening. Same angioplasty, same ascites, liver problem, same MI. So now the trick, doctor, is number one, forget about the habits. Number two, assess his knowledge and relate. And what? The habit to the condition. Because unless you make this relation, Why should I stop? I love my cigarette. I love my shisha. Yeah, I love it. Why should I stop? Unless you make the relation at first. This will cause this and scare him. It's fine. Scare him. Then when he knows the relation, then it's easy for you to talk about smoking. Then he cannot say to you, why should I stop smoking? Brother, are you stupid? We've just been talking for 10 minutes. You're gonna stop because you're gonna die. So he will not ask because you relate the relation with the habit to the condition. A patient who's refusing to walk. By the way, this is a case. A patient refused to walk. I managed 6 years old. Do you know why you're here? Yes. Because of my heart problem, this terrible problem. You know what is heart attack? No, it is such and such. You know what can cause heart attack? No, 1, 2, 3, 4. So let's have a chat because we need to decrease the risk of this. Then talk about the habit or the stuff or the walking or whatever. Guys, alcohol, smoking, Dr. Am, all the time. They will give you a relation in the question. They cannot give you just go and talk to this patient about smoking. No, that doesn't happen. They have to give you a relation. Why would you? So would you start with the habit or would you start with assessing his knowledge, making him understand? But please, don't get carried on with assessing his knowledge. Don't spend 2 hours telling him about, that's not my main concern. Assessing the knowledge and telling him about the reason, 1 minute. Do you know why you have? No. Heart attack. No, heart attack is no. Decreased blood supply blockage. It is life-threatening. It can lead to sudden death, for example. This condition have many reasons. We don't want this to happen. So it's okay, we have a chat. So we decrease it. Yes, station started smoking. For some doctors, they start talking about smoking at 6 minutes. Smoking after 1 or 2 minutes. That's it. And when you ask about smoking, what is the first question?
For how long?
What do you smoke?
What do you smoke?
What do you smoke?
Yeah, maybe I smoke cigarettes, maybe I smoke cigar, maybe I smoke shisha, maybe I smoke weed, maybe I smoke cannabis, whatever. So, what do you smoke? Okay? Okay. When you're talking about alcohol or smoking, right? Sure. Okay. هذا الهواء So alcohol, talk about alcohol or bite any habit. What is the main thing? صحيح عشان التليفون كان مقلوب صح؟ طب ما كده افضل، انا ما كنتش عاوز من الاول.
تفتح انت تشوف الموبايل.
ها؟ لا that's the best way. Yeah, so I can see. What did we do last time of this? So the most important thing here, do not judge. Do not judge. What is the meaning of do not judge? When you talk about a habit, make sure at any point, I am not going to say anything that will make me feel that you are judging my habit. And make sure you acknowledge. What is acknowledgement? If you talk to a patient about smoking, is it difficult to stop smoking? Yes or no? So please all the time, Mr. Andrew, I can see that it's tough. Yeah? It is not easy. It is difficult to stop smoking. So please, Dr. Hamid, when you acknowledge the fact that it's difficult, that makes me. But some doctors say it without me saying it's difficult. So, well, I highly advise you to stop smoking. I can see it's difficult, and I say, no, it's not difficult. So don't say it's difficult until he shows you. Don't just say, well, I can see it's difficult without me saying it. So let me, could it be, for example, I smoke shisha. So you speak to me, doctor, no, shisha is not good for you. I think you should stop it. What will I say? Okay, it's fine. If it's not good for me, I will stop it. But that's what doctors do. Well, I highly advise you to stop smoking shisha. I can see it's difficult for you to stop it. And then I say, well, it's not. So let me show you. And then you reflect. Okay? So don't judge.
Maybe you can replace it with it like it's, I can see that it's important thing for you.
Yeah. Okay. It's important to stop it. Yeah. So don't judge, Dr. Karim. Acknowledge the struggle, acknowledge the difficulty. Okay, and always ask about open question. Open question. What is open question? Don't say to him when you talk about alcohol. Always better to make it open. Can we have a chat about your smoking habit? Is it better? Or should I ask a closed question? Mr. Andrew, I'm here to talk about smoking. Tell me how much. No. Can we have a chat about smoking habit? Yeah, I smoke for 10 years and I smoke because I'm stressed. So the fact that you're leaving it open, it will make him tell you the things that you want to know. And maybe the things that you will not ask. So please, how do you feel about your alcohol habit? Can we have a chat about your smoking habit? Dr. Hamid, can we have a chat about? That will give you better chance for you to hear. Don't judge, acknowledge the difficulties. Okay? Always, because you forgot now, the most important thing is to what? Relate. Tell him first. That's why you have assess his knowledge in alcohol and smoking. All of these are cases. Patient refusing, MI refused to walk, angioplasty smoking, liver problem, alcohol. All of them, I will start with the alcohol or the condition. Let him know the condition. Then ask him about the causes. No, he doesn't know the causes. Then relate the causes to what's happening. Okay? Okay. Talking about lifestyle, guys. Talking about lifestyle is again OSCE in the exam. What do you mean? Talking about DESA is an OSCE in the exam. You must have an OSCE where you will talk to the patient about DESA. I must. Yes, you must. And what is the problem in these cases? Guys, when I say you must, it's a case. The problem that we talk about DESA at 6 minute bell. We talk about DESA at. Can you give us an example from our, what we need? 65 years old, being admitted in the hospital for MRI. Okay. He's being managed. He's going home. the consultant asked you to talk about lifestyle modification. Then people start talking about lifestyle modification at 2 minutes. What is your task? What is your task?
Lifestyle.
Which is DESA. This is the station. So you should be actually talking about DESA after 2 minutes. Guys, it's a case, yeah? That's a scenario. Okay, how do I do that? Mr. Alex, do you know what you have? I can see from my note that you've been admitted, yeah? I had heart attack, doctor. It must be terrible. I'm sorry about that. How is it managed? Yes, doctor, they give me this and that and this and that. You know, do you have pain now? No, doctor, I don't. Well, Mr. Alex, do you know what heart attack is? Same concept. No, doctor, heart attack is decrease or blockage in the blood supply. It is life-threatening. Do you know what causes it? Well, no. Well, sometimes the fact that the age, the fact that it's family history runs in the family. However, there are some situations where if we work on, will improve the chance or decrease the chance of you having this. So is it all right if you have a chat about some lifestyle modification in order to decrease the chance of you developing this terrible life-threatening condition? Yes. How long did it take for me now that what I said? What I've said, how long? But with the patient talking, say 2 minutes. That's it. How is your diet? Advice. How is the exercise? Advice. Alcohol? Advice. Smoking? Advice. Dr. Hamid, after 2 minutes, because this is your task. Your task, Dr. Ward, is to talk about it and give him the chance to say no and say why, and we can do that. Smoking? No. Why? You can do that. So the 6th minute will give you the chance to. So guys, please, lifestyle modification, MI, very important scenario. After 2 minutes, you should be managing DESA. You should be asking about the diet and managing exercise. This is not a case of family history, medical condition, medications, allergy. It's not. It's not. It's not clear. It's not. It's not medical condition, medication, allergy, high blood pressure, heart problem. It's not. The guys managed. Talk about this. But the approach is to educate him about. Why do I educate him about the heart problem? Why? Because I want him to be educated? No. So he's convinced. When I talk about DESA, he knows it's the cause. Okay. When I'm talking, Dr. Hamid, about lifestyle, should I acknowledge the difficulty of the problem? Do you know what I mean, guys, by acknowledging the difficulty of the problem? Guys, please. Does anyone smoke here? Unfortunately, no. Nobody smokes here? You smoke, yeah? Yeah. Is it easy to stop smoking? That's life. That's huh? Very difficult. Guys, it is difficult. So please, I'm not asking for, what's your name? Dr. Ahmed. I'm not asking for, so Dr. Ahmed, you know, smoking is not the reason why, you know, you can have this problem. So it's okay to stop it. Well, I can give you a batch, nicotine batch. Well, you know, I mean, you can refer to smoking clinic. You know, guys, it's not that kind of case. That's why I said, how long do you need it first before you start talking? 2 minutes. And the 2 minutes only, doctor, educating the condition. Why? So later on, educating and tell him it's life-threatening, scaring him. So that should be the case of me now talking about the smoking. Well, Dr. Ahmed, from what I've told you, that smoking is not the reason why you will be having this condition. I mentioned it is life-threatening, and smoking is a major risk factor. It is a risk factor for this condition, yes.
So I need something to help me stop smoking.
Well, Dr. Ahmed, we can help you with that. Okay, but as you mentioned, we've been smoking for 25 years. Okay, sometimes it may be quite challenging but it's all depending on the willpower as well. Okay, so many things we can do to help you quitting smoking. Would you like me to discuss it with you?
Yeah, please.
All right. Well, first of all, we have some nicotine patches that we can give you that will actually deliver nicotine to blood. Yes.
Yeah, I tried it before, but it gave me after.
Did you hear this? He said what?
Right.
I tried it before, but it gives me heartburn. Now I have the chance to say to him, and did you try it by yourself, or was it like a doctor advice?
No, it was from over the counter.
Over the counter?
Yeah.
All right. Okay. Well, this time we can prescribe it for you. You've mentioned that it causes heartburn, maybe because you're overusing it.
Yeah.
So we can actually prescribe it for you.
Actually, I was using it with the Nicorette gums also.
You see, now the patient has concerns. But if I start at 2 minutes, will I be able to have this kind of chat? Guys, you get my point. So the problem here is when you talk Dr. Hamid about DESA, you need to have your time. It's not a matter of smoking high by stop. And when I'm telling him now about smoking, well, I advised him about DESA, about smoking, whatever. Well, you don't need to decide now. You can go home, give it a thought, and then see what suits you better, and then we can discuss this later.
Right, okay.
What did I do now? Do I need today to force him to stop smoking?
No.
Guys, always leave it open like this. Seriously, Allah, it will make a nice impact. You don't need to be stop it now. It's fine. Give it a thought. Go home. See what appeals to you. Is that only in smoking or all the lifestyle? See what appeals to you, and then we can have a chat later about the best option for you. Again, diet. Okay. Well, Dr. Ahmed, from what we spoke about, well, diet is a really factor here. That if we work on diet, if we make sure that you are eating a healthy diet, well, that can decrease the risk of you having a heart attack.
Oh, really?
Yes, it is. So is it okay if I have a chat about it?
That's all right.
Well, you've mentioned to me that you eat a lot of takeaways and you also like eat pizzas and burgers. Well, you also mentioned that you have a busy lifestyle. So I totally understand it could be tough sometimes to get rid of this like takeaway kind of food. But is there anything in mind that you can think of in order to make sure that you are leading good diet, you are having some good food?
Well, I'm not quite sure at the moment, but I'm considering, is there any takeaways providing healthy food maybe?
Well, we can look into this, but I'm talking now about cooking food at home. Is there any chance of you, for example, having a friend? Do you have anyone to be at home?
Well, regarding this matter, I can cook for like a whole week meal
Oh, wow.
one day. Yeah.
Okay.
I can definitely manage that.
That's it. Good. So we can.
But the problem is, doctor, I don't know how to cook. So is there any?
You can get married then.
No. I like to be single. So is there?
That's guys. I'm not gonna tell my patient you can get married in case because he answered me. But that was a joke. Yeah. He's not gonna say that. Well, so you don't know how to cook. Yeah. Okay. You can actually look online to see if there's any home cooked food that gets delivered. So what do you think of that?
Yeah.
Yes. Guys, it's kind of a chat. I'm not gonna have it if I have only 2 minutes. And by the way, yeah, friends. Huh? Yeah. Huh? Levnina. Guys, by the way, these kind of stations, your task is the lifestyle. So please, if you do such a station, if you have a station talking about lifestyle, the whole of the history is just the 2 minutes relating to the condition, and I should have my time because these kind of stations are so challenging and convincing. And if you are pushing him, you're not going to convince him. You need to give him his time. And whenever you finish a lifestyle, always end it by. Take your time. Think about it. We can discuss it later. It's fine. Guys, your task is not for him to stop now. Clear? And as I mentioned, whenever you talk about lifestyle, Dr. Karim, always talk about the risk of not doing it. Because that way you're scaring him. And if he doesn't know this, he might not stop. For him to stop, he should know the implication of not stopping it, guys. Okay? Look, this is like one page. Yeah, this is like one page. I will tell you what I've mentioned because lifestyle modifications, I'm sure you keep on eyeing things. It's important in exam. Look, this is the page for lifestyle modification that I was talking about now. Just one page. I said, first of all, assess the patient knowledge about his condition. Then relate. Then what? His condition to the matter, related to smoking, condition to alcohol. Then I said, either talk about the risk of not following it or the benefit of following it to convince him. What will happen if you don't? Boom, 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 boom. That's why you want to convince him. And always acknowledge that challenges. The patient, Dr. Reda, is it easy to stop smoking?
For me, it is not. But for the patient, I don't know.
Yeah, no. Is it actually, I'm talking about real life. Is it easy to stop smoking? Stop now? If you come into a doctor in 8 minutes, is it logic for me to convince you and you leave the clinic without cigarette وخلاص you throw the cigarette? That's my point. Is it easy? No. So that's why in the exam, they want to see this from you. In the 8 minutes, I don't want you to make me stop. No. Tell me what's happening. What will happen if I don't stop it? This, that, and give me the window. You tell me. Have your time, give it a thought, and see what's going to happen. Okay? Acknowledge the difficulties and always focus into the importance of modifying the habit. Focus, because that will make him want. Okay? Okay. There is some scenario recently, yeah, about bereavement. Some scenario recently. If you have a patient, so bereavement, okay? It's a case of a patient of who's, for example, lost someone, lost his father, his mother, and he is in this stage of depression and low mood. In these cases, I need 3 things. I'm talking about from communication skill point of view. Very important, yeah? I need 3 things, Dr. Hamid. Number 1, acknowledge the challenging time he's going through. Number 1, what? I can see you are going through tough time. It is a challenging time. What you're going through is so difficult at the moment. I can't even imagine what you must be going through. Now, when you acknowledge the difficulty of the time I'm going through, that's a big point of starting your station. What is the 3 points? What is the second point? Of a patient who's coming to you, bereavement, he's depressed because he lost someone. Number 1, acknowledge the fact that it is challenge. Please acknowledge. Number 2, reassure me. Reassure me, Dr. Hamid, it is a matter of time. Reassure me, Dr. Hamid, it is a normal healing process, a stage in the healing process. Reassure me I will be okay. Reassure me it's gonna be fine. Reassure me this bad time will pass. Reassurance. In such cases of bereavement, depression. Bereavement, low mood. By the way, we know depression, so secret suicide, we know this. But I'm talking from a communication skill point of view. I want to acknowledge the difficulties. I want to reassure you that, well, nobody will forget the beloved ones. I don't think that you will ever forget the beloved ones. But what are you going through now? This is a part of the healing process. Clear? What is the third step and the last step in this kind of cases, apart from the medical part of the suicidal part? And what is the third step? Support system. Support system. Support system. Support system. Support system. And under the support system, write 4 words. You. What is you? The doctor. I'm giving you support whenever you need something. Relative. Friends. CBT psychiatrist. That's the management. So again, you and relative, support from friends, distant. I'm going distant. Yeah, me, you are in my clinic, yeah? I'm the closest person to you now. You are in my clinic, so me. Then when you go home, relative. Then friends, and finally we can refer to CBT, token therapy. So 3 things, huh? 3 things you're talking about in a bereavement case. Acknowledge stuff, reassure, it's a part of the healing process. By the way, guys, don't forget the medicine part, the suicide and what we go through. Make sure you reassure, and make sure finally you talk about 4 things in the term of management: my support, friends, who do you live with, who's at home, who's around you, any close friends, and finally we can refer you for talking therapy. Medical error. Medical error. Medical error stations. Doctor, in medical error station, a mother whose son had medication is allergic to. Okay? Talk to the mother at this concern. You open the cubicle, the mother is angry. What should you do? Acknowledge the fact that she's angry. I can see you are upset. Then what to do? Or now things that's it. You should acknowledge. I'm upset. Then what to do?
Make sure that
Tell her you have the right to be upset. I can't see why you are upset, because the question is written. Your son will give in. It's okay if we have a chat to move further. Our main concern is your son, to make sure he's okay. Move further. All those guys, Dr. Hamid, try to take the patient and go beyond. After you acknowledge the importance, she's upset, she has the right. Then, after that, we're moving forward. What should my history be? Sorry? Why is she angry? Because of he was given medication. So this is my history. This is my relevant history. Is the condition. What happened? What was he given? He was given such medication. What symptoms did he have? Is he short of breath? Any rash? You know, my relevant. Guys, do not take long history. Do not take history about family history of anything. And no. My history is the instant. Relevant history is the instant. Okay, another example. Foreign body. My son was sent home and first thing. I can see you are from the start, I can see you are upset. You totally have the right to be upset. If it was me, I would feel the same. My main concern is your son. Let's move further. Let's move further. What is further? History. What is the relevant history? Foreign body. Is he eating? Is he drinking? Is he passing his stool? Any shortness of breath? Any, you know? Because foreign body can be either in the food pipe or down the pipe. Food pipe, vomiting, constipation. When the pipe? So assess. No, doctor. So the history is relevant to the incident. Don't go bird triple D. Huh? Don't go into the pediatric structure of bird triple D and don't. Because this patient will need time to convince and time to. So the patient had foreign body, 5 years old. What is development to do with the foreign body that he had? Huh? Seriously. So my history, Dr. Karim, will be focus, relevant. You remember when I said to you, the patient complaining, my history will be relevant to do with the complaint only. He's complaining with this. So this is my history, and this is my management. Now, Dr. Hamid, you will finish early, and you will address the patient concerns. She's here for this. So my history will be only the foreign body, the missing foreign body. What did he have? What did he take? Is he eating? So harm. Is he fine? He's fine. After taking history, I assessed his condition. Now, in this kind of cases, she told you that the doctor sent me home. Well, this doctor is a donkey in Egypt. Who's that donkey? Send you this medication? Yeah. Don't blame anyone because you don't know what happened there. Yeah. Could something be missing and it's actually a part of? Yeah. So don't blame anyone in a patient who's medical error, please. Dr. Hamid, in a patient who's coming, don't blame. You don't know what happened, you don't know the situation. Okay? Because blaming will give her the right to do things that maybe she does not the right to, but you give her things in her head. So don't blame. Were you there? You know the situation? No. After that, make sure in a medical error station, write a big word here, because it's a very common in the exam, medical error. Write a big word. Be honest. Write big word, guys. Be honest. يعني يا دكتور حواس ليه be honest. Don't lie. Don't make things look nice. No. If there's a problem, there is a problem. Foreign body is missed, I'm sorry, it is missed. Do not lie. Because some doctors, they feel that they can lie or twist, so they don't make the patient angry. Be honest. If it's written outside the question, junior doctor, be honest. I'm sorry, junior doctor is sorry. It is not a come back again to an hour ago. It is not. Huh? Accept it. There is no excuse. I'm not trying to give an excuse, but this is what happened. Am I honest? So don't give an excuse. Be honest. Be open when you tell her. Apologize. Now, I acknowledged. I asked her about the complaint. What happened? I only asked in history about the case itself. I don't care about the triple T, you know, the case itself. Then, did I blame anyone? I don't, because I wasn't there. Any excuse? No excuse. Even if there's a reason written, well, it's not an excuse. But how to manage?
How can we move things forward?
Number one, the instance. What? That's my point. In management, make sure the medical management, examining and investigation, scan, repeat the scan, and after that is other things. Do I offer apology? Do I offer complaint department? I don't. I don't, guys. I do not offer complaint unless she asks for it, or unless Dr. Ahmed, I feel she is intending and keen for it. Okay. What is that third? So I will. Do I offer it? No. Only if she won't, or if you can see that she is keen to complain. What is the third point where you can offer a complaint? Third condition where you can offer. Number one, if she won't. Number two, if she's showing you that really she's not satisfied. What is the third point where you can offer complaint? If you hate your friend, if you hate your colleague is not good, bad to you, then you say to her, don't complain. There's a complaint department in the house. It's fine. It's good. Yes.
Doctor, معلش, should we offer instant form order?
Definitely instant form will be, you're not going to offer it. It will be filled. Instant form. So instant form will be filled. Yeah? Yeah? Number two, there is a meeting called the root cause analysis meeting. I've never had it ever in my life. I've never heard about it. It's not on any hospital. It's not, you don't hear about it in hospitals here in UK. No. You understand? But you can say, well, we can prevent this from happening in the future. We can get to the bottom of this and try our best to prevent it from happening. Okay? So paperwork is instant form and meeting to prevent this from happening. Don't even say root cause analysis meeting, because 20 out of 20 will be saying it, and it's not anywhere. Understand? It's not even like, just say, well, we'll try our best to get to the bottom of this. Yeah? We'll see what caused it and we'll try to prevent it.
At this station, the medical error, should I start with assessing the child at first, or inform her the error at first?
Well, one of the doctors saying, should I start assessing the child harm first, or should I tell the error first? Logic or safe, assess that. But some parent, what do you want to do? I mean, you send me home. Why do you want to know about him? What can you know about? Tell me why. I went to home. I'm home now. So some parent will drove you to the fact that you give them a reason why you are asking. You understand? Sometimes it's smooth. Some parent, how is he? Is fine. But some doctor, don't you think it's strange to call me to ask about him? You send me home. You discharged him. Is everything all right? Then what can you do? Can you say to her, yeah, everything is all right? No. Well, yeah, it's all right, but can we have a chat? No, I'm really sorry to tell you this. Today, you came to the clinic or to the A&E. There was a foreign body, but it was messed. I'm sorry. I'm trying to make sure he's fine now. You understand? So depending on the situation, some parent will drove you to say it before anything. Okay? Sexual history. Guys, you cannot pass lab to guys. Is there any benefit? Or if you go, no offense. Go. Seriously. Be selfish. If you think there is nothing you are adding, you have something else you can do, it's fine. So, guys, we are going around a circle of. I can see you are upset. Yes. You have the right to be upset. Don't give excuses. Don't blame anyone. Always try to move forward. Now, sexual history. You cannot pass lab 2. Let me assure you, without having a station about. You can't. Why? Because what's common is common. In UK, I have never myself in Egypt paid attention to STI. Understand? I mean, we don't. Always in the curriculum, you cross it. But STI here is topic. So you will not pass through lab 2 without having a station about either STI or COCP contraceptions. So sexual history. A station of sexual history, which you must have. You cannot ask sexual history without telling me the reason why you are asking. So in a sexual history, please don't say, are you sexually active, while you're just asking about diet. Number one. Number two, so number one, signpost. Number two, when you signpost,
the best way of signposting. The best way of, what is the best way of signposting? How can I help you? The patient to give me discharge, then to me pay. It's the best way and it's new. It is the best way and new means it's fresh still. So you understand? Give a reason. Well, after you've already taken some history, you gathered pain, discharge, then before sexual history, you will say. When you call, sometimes when you have patients with symptoms like what you have, like discharge from the passage, tummy pain, pain while passing urine, we tend to ask them some questions about their sexual life in order to get to our diagnosis. Would that be all right? So why am I asking about sexual history?
Because he has
Huh?
certain complaints.
Because it's related to your condition. Then ask sexual history. So please, before you ask sexual history, signpost it in that way. Mr. Anthony, sometimes when we have patients that complaining from headache and complaining, for example, whatever, they tend to have discharge from their breast. Do you experience the same thing? Milky discharge from the breast. Do you experience the same thing? So I'm actually relating, before I give him the question, I'm relating. I'm asking you because these conditions brings me to this question. Clear? Sexual history, please signpost with the relevant symptoms that you have. Okay. You know, when you are taking sexual history in such cases, the patient may be embarrassed. A patient may be shy, embarrassed. What to do if the patient's embarrassed? Can you please, guys, acknowledge the embarrassment? What else?
Reassure him.
I can see you are embarrassed. And what else? Assure him. Well, please don't be. Every patient walk through this door, they have similar conditions. Please, it's something that I can see, that I see in the clinic here every day. We are used to see such conditions every day. Please. So Dr. Hamid, show him that, don't worry, what you're having is normal. We are used to see this every day, it's fine. I personally come across many conditions like this. Please, don't be shy. Okay. So please, all the time, always try with a sexual history. Don't be like, are you sexually active? No, don't. And try when you talk, the tone of the voice, the body language. Well, Dr. Ward, you know, sometimes when you have male patient with pain while passing urine or discharge from the penis, we tend to ask them some questions that may sound intrusive, as some questions to do with the sexual lifestyle in order to reach our diagnosis. That you're right. Yes, doctor. Then ask, are you sexually active? Do you practice safe sex? Do you have a stable partner? You understand? So please relate the symptoms. Now, when I'm talking to Mr. Donald, it's fire, just a fire. When I talk to Mr. Ward, and Mr. Ward is embarrassed. At first, I open the clinic, the door, he's embarrassed. What to do? Mr. Ward, I can see you are embarrassed. Mr. Ward, everybody walk through this door. Yeah? Dr. Karim. Mr. Ward. Yeah. Mr. Ward, everybody walks through this door have a medical condition. Please don't be embarrassed about it. Mr. Ward, I've seen such complaint. I came across such a complaint many times. Please feel free. That's nothing to feel embarrassed about. Hey, Dr. Hamid, كده حاجات كده ها يعني try to make it's normal. Mr. Ward, this option is not going to happen. Why is not going to happen this option? Because this option, if it happens, you're not gonna have the station. I mean, it's. I'm just gonna say, and he will say no. If I am a female doctor, if I am a female doctor, and I'm talking to a male doctor, and his complaint is ulcer in his penis, and Mr. Ward is embarrassed, what's gonna happen? I can see you are embarrassed. Yeah, please don't breathe. I came across such conditions all the time. Nothing to be embarrassed about. It is a common clinical scenario that we come across. Let's see if he's embarrassed. Mr. Ward is still embarrassed. No. Mr. Ward, if you don't feel uncomfortable, if you if you feel that you have a specific gender that you want to talk to, if you want to bring you a male doctor, feel free, please, I can do so. He's gonna say no, and this is the end of it. So you can offer him what? Another gender, which is, if I'm a female and he's a male, I can offer him a male. If I'm talking to a female, Dr. Hamid, I'm in the exam, I'm in the offer, and she will say no, and that will make her. Can I offer? If a female will not talk unless there's a female doctor, can I offer or not? Huh? Like my wife, for example, when there's any gynecological problem, she will be only seen by a female. She's not going to be seen by a male. Does she have the right? Yes, it's fine. So please do offer this as an alternative. Offer this as an alternative, please. Okay? Which is not going to happen, but it will be easy. It will make things go forward, and this is the last stage of the embarrassment. So, sexual history questions we know. Are you sexually active? Do you have a stable partner? Do you practice safe sex? Yeah? Okay. Now, we finished the history part, and in a sexual history, what is the management? Write 4 words. One of them, short notes of it now. Allah, this short note of it, but I'm trying to push because of I don't want to just like elongate it, so you know. So in a sexual history case, my management tried 4 words. 4 words. In a case of STI, mostly gonorrhea, chlamydia, write 4 words: investigation, in brackets, STI screening. Second word, antibiotics. Third word, partner. Fourth word, safety net, in brackets, safe sex. That's it. That's the whole station. Again, what are the words? STI screening, antibiotics. So me, antibiotic, partner, safety net, safe sex. 4 words. You want to cover them in management. Do we forget some of them? Of course we do. When we practice, do we forget? Plenty of time. So 4 words: investigation, manage the partner's antibiotic, manage her antibiotic, partner management, safety netting, safe sex. Okay.
Doctor, they are managed in GB or should be referred to GOM
GOM
clinic?
clinic. The question will be GOM clinic. Guys,
If it's GB.
the STI, GOM clinic. If it's GP, you can start antibiotic, but she will need GOM clinic.
In case of syphilis, I will give him the injection for
Yes, guys, and you refer to GOM clinic. You manage, you start the antibiotics, you start the medication, and you refer to GOM clinic for what?
So his for screening and his follow-up next week will be in GOM.
Yeah, other STI. You must refer to GOM clinic. Genital clinic. And GOM. Okay, not chewing gum, GOM clinic. GOM clinic, GOM clinic. Okay, today, this topic now. So if a patient is coming to GP, a patient is coming to who? Just as an answer to Dr. Ward's question. And she's coming, very common, GP clinic, and you suspect it in the GP PID. What did you suspect?
PID.
What to do?
Start management, refer to gyno.
Start antibiotic, refer to gyno. And do you say we'll refer to gyno for what? For further scan, vaginal scan, you know, and. But you will start antibiotic. Clear, guys? You must. A patient who's coming to you, is suspecting a PID, you will start management.
Even injection, I think instead of saying injection, or offer her injection first in the clinic.
If you are in a GP clinic, she will be given injection, no problem. Start ceftriaxone, and she will even start on the tablet antibiotic, because you know PID, we give injection and we give antibiotic for 14 days. 14 days, 2 medication. Protocol: doxycycline, metronidazole. I will start the antibiotic course, and yes, she will go for the follow-up with that gynecologist, because they will only do scan. The GP cannot do transvaginal scan. But think about it. I don't start her antibiotics and I leave her to be referred tomorrow after tomorrow. You think? Gone. So no, you start and refer. Okay?
The problem is in conforming the diagnosis. Sometimes the screening will be in the gum. So how I'm sure that he is having syphilis, so I will give him this. But I
Guys,
didn't
there is some
understand yet.
scenarios where the case is confirmed. Gonorrhea, swab was taken gonorrhea. And there is some scenarios. So some scenarios, there's 2 kinds of scenarios. A newly diagnosed, tummy pain, discharge. And there's another scenario, 25 years old, coming for the follow-up, swab was done, showed gonorrhea. That's confirmed. That's no referral, no nothing. It is confirmed. Start right away. Am I making any sense? So the patient who's confirmed, he will manage antibiotic. But the patient who's newly diagnosed, then you can give and refer. You understand?
لا لو سيفلس وانا اللي شخصته هديله الحقنه
Yes.
لسه انا ما عملتش الانفستيجيشن اللي ياكد انه هو سيفلس.
Yeah, that's one thing. No. Guys, syphilis, I would suspect me as a single painless ulcer in the penis or in the scrotum. Single painless ulcer in the penis scrotum. The patient will give you sexual history, anal sex, will tell you, I've had anal sex, I've had unprotected sex. I will manage syphilis and I will refer for other STI. Okay? Okay, clear? And okay, anyway, so when I talk about situation scenarios, I've heard that, I knew it, and you know, like it's not like you understand, but I can't. Sometimes you can't like say consent. Let's end this topic. Let's end this topic. If a patient, guys, we hear a lot about what about she's 17? What about if she's 18? What about if she had sex and tomorrow's her 18th birthday? What's going to happen then? You understand? So let's end this topic. The age for consent when it comes to sex is 16. Again, the age for when it comes to sex is, so any patient over 16. Okay or not? Okay? Okay. Any patient under 16, you must assess mental capacity. This is the rule. You right? Yeah. So any patient, guys, any patient over 16, do you want to ask about the age of the partner? No.
No. Yeah.
Like 5 minutes, they take the shutters right now.
That? Yeah, they can come
This is outside.
Sorry?
This one.
This, yeah. Okay. Okay, guys, can we just
معلش بس can you move these? This no.
it's fine. I'll just give it 2 minutes here. Not 18, no, 16. Guys, still taking this one. Oh. Can you just come this side? Take this one. That didn't take no. Yeah. I don't know. That's anything else? تمام. بص يا دكتور مصطفى هم ماشوا صح؟ ماشوا. تاني هبقى harsh with them. Like harsh. Be harsh with him مستري. harsh. قول له إذا في أي حد محتاج أي حاجة أو كده تقول لنا in advance ومحدش يخش كده إيه.
It's fine. I'll talk to him later.
Guys, let's start. So now the age for consent or capacity consent for sex is not 18. Is not 18. I'm saying it now. Can you see? Loud and confident. Yeah. It's 16. It's not 18. Yeah. So above 16 is fine. Under 16, you must assess the mental capacity. Huh? Assess mental capacity. Yes, we need to draw this. Yes. Dr. Reda, you should understand this. So in the exam, you know what's happening, not memorize it. Yeah, guys, 16. Yeah, 13. Okay, above 16. Can she have sex without the consent, obviously, like consensual mutual between her and the partner? But I'm saying, is it okay to have sex? Yes. Over 16. Okay. Under 16. She can have sex, yes, as long as she has and the partner same age. So yes, she can, as long as she has mental capacity and the partner same age. Under 13. So 13 to 16 is that, yeah? Under 13. No. So 16 years old over under 16.
Okay, once she has mental capacity, partner same age.
Under 13. Clear? Okay. Huh? 16 yes 16 and over guys.
Okay.
Under أكبر من أو يساوي. You know, this is in math in Egypt. Yeah, 16 or over. Yeah. So under 16 to 13, mental capacity and age. Under 13, no. Okay. When I say mental capacity, Dr. Mo said mental capacity, but in the station, how do we know? She's coming for emergency contraception. She's coming for? How did you hear about the pill? Well, doctor, I heard it from my friend. Okay. So, do you know what will happen if we don't give you the pill? Yes, doctor, I'll be pregnant. I don't want. Does she have mental capacity?
Yeah, she knows that.
Yes, she knows. The pill is for pregnancy. She heard it from her friend. She doesn't have it. She'll be pregnant. So, mental capacity, when you say make sure she has mental capacity, it doesn't mean that. No. It's from the conversation. If I'm talking to someone who's mentally retarded, if I'm talking to someone who's got mental problem, wouldn't you be able to know from the way you're talking to him and the way he answers you? So if the conversation is smooth and everything, then she has mental capacity. And how would the examiner know? That's why maybe some of you study the script of the emergency contraception, not knowing why should we ask. Do you know what the pill for? Yeah. You know what will happen if you don't take it? I will be pregnant. I don't want to be pregnant. Yeah. So, but in management, I will say, well, I will give you the pill, definitely. Because from what we spoke about, I did assess your mental capacity and everything is okay. You know what's happening? You know, why did I verbalize this? Huh? For the person who's hearing to know that I know. Because maybe he did not get the attention that I know mental capacity. So verbalize it. Say it to her. Am I making any sense? And you will say, from the information and from the chat that we had, you seem to know the implication of not taking it and why you want to take it, which for us, we call it mental capacity. So you seem competent and I will give you the medication. So 15 years old, having sex with 14 years old, 16 having sex with 14. She has mental capacity. عيال مع بعض يعني. Is it any problem? Do you need to inform anybody?
No.
Okay. She doesn't want to tell her family. Does she have to tell her family?
No.
You understand? You don't even need to advise. It's fine. If she shows you she's scared, you don't even tell her, but I highly advise you. No, it's fine. Okay? Over 16 or over, it's okay. Clear this? What about 14? And the partner is 14, but no mental capacity. Huh?
No.
No. There's no mental capacity. Yes, she's 14. Yes, she's 14, but no mental capacity. And the example for this is the emergency contraception station. Okay? 16, above 16, below. The example, emergency contraception. Okay?
For family.
Huh? Yes, family social service. Anyway, patient okay, non-accidental injury. We nearly finished. Non-accidental injury. A mother, Nicola, Adam's mother. Adams is 9-10 months old, 1 year old. She brought him to the hospital because he's having tenderness. He's having what? Tenderness in his arm. Talk to her. Address your concern. Non-accidental injury. It's a case. I don't know yet, but I'm telling you, I'm going to discuss now onto this scenario. In non-accidental injury cases,
make sure. Number one, I will start my question. I will start my consultation by open question. Can you please tell me what happened? Do I start my consultation with blaming and how did he hurt his arm? Tell me. Huh? Tell me what happened. No. You don't know. Because in the question, tenderness in his arm. So start with open question. Can you please tell me what happened? She will tell you, doctor, and she'll give you story, wrong story. He fell and this and that. The main thing here that will make you realize it's non-accidental injury from her conversation, because the question at the door, will it say non-accidental? Okay. But what will make me think of non-accidental? Okay. Number one, two things will make me think of it. Number one, delay presentation. Number two, that the story that she will give you all the time is not going to be matching the injury. So the injury will be spiral fracture, but the story, he had a fall of the couch. Would the fall on the couch make the arm twist? So it will be a normal station. She is coming, and I will assess, I will find out, Dr. It is non-accidental by number one, she will tell you he had an injury 3 days ago. She bringing him today. What is that? Number two, she will tell you he had a fall and the question said spiral fracture, or the question said twisted arm. Is it matching? Is it matching? What if the question said twisted arm because this happened? Yeah? And they give you a story. The question of the door said arm was twisted. Arm was twisted. When you get in, what happened? Then in presentation, then you get in. What happened? Doctor, my son just an hour ago had this tenderness pain and I'm very worried about him. Can you tell me what happened? Well, doctor, he was about to fall off the couch and my partner was trying to pull him and he pulled him from his arm while he was falling and he twisted. Not in the injury? No. The person was called was 2 that day. And people, all of them thought it's not non-accidental. It could be, yes, but the more you talk to her an hour ago, no delayed presentation, a happy family, everything is okay, everything is fine. Yes, it's twisted arm, but yes, he was falling off the couch and he was holding him from his arm, got twisted. So it's not non-accidental injury. So my point is, non-accidental injury is a father or a mother who's careless, a child who had an injury 3 days ago, a child who's being raised with a man who's not his dad and not, for example, his biological father. She told you he had a fall when his arm was twisted. Did you understand anything? Clear? So delayed presentation, story doesn't match. And number 3, the mother is a careless mother. What do you mean? Please, quickly. I'm going to have my hair cut and I'm going to have my body waxed and please, I'm going, while his son is in front of you crying. Or while his son has just had injury and fracture. That's not an injury. Okay. One word, non-accidental injury. Environment. No, I'm saying history. One word, non-accidental injury. Guys, forget about everything. How can I help you? Doctor, my son is having bruises and pain in his arm. The first question needs to be open. Tell me what happened. She will give you a story. She will be careless mother. When did it happen? 5 days ago. So far, anything you need to memorize? No. Once you get this presentation of a delayed presentation, careless mother, this and that, one word to remember is environment. Who's at home? That's it. Who's at home means who is at home? My partner and my stepson. Stepson is her partner is having a son from, and my son, and this one who's injured. You need to know the relationship between the son who's injured with every single person. How things at home, the relationship. So number one, environment. What is the second word? Second word, I mean, environment, and what else in the history? Stressors. Write down the word stressors. Can stress lead to parents abusing kids? If you don't have money, can it be? Maybe alcoholic, maybe drug abuse. So stressors. So write down environment and stressors. Alcohol, smoking, drugs. Sorry? Yeah, money. I said money and drugs and yeah. Provisional diagnosis. Guys, is it covered? The history and the story and the environment and the stressors. Environment and remember two words. Environment and stress. Because when the family don't have money, they get stressed out. You feed the kids, Okay. In provisional diagnosis, how to tell, how to say provisional diagnosis, and how to manage. Well, management, we know. Senior, you need what? Full skeletal survey. What else? CT head fundoscopy. What else?
Social service.
X-ray.
Photography. You're gonna take photos of the injuries. Why? For court. Why? For court. This is the case. I've seen the child done. Social service will take the child, and then later on they will go to court. The family want the child, and the other one the social want the child. Why? They will have their story. They will have their story, and then you're gonna have the pictures. That's what the child came. So photography. You're gonna take pictures of the incident, of the injury, and then you will say to her, yeah, painkiller and orthopedic and X-ray. Yeah, we know this. Yeah. Then how to tell her at the end? Well, I'm a bit concerned about Adam. I'm a bit concerned about that's at the end or at the start? At the end. So I started my station with history. How many words? Then I came to examine, and then I started managing. And when I started managing, I managed investigation, skeletal survey, everything. And then I said to her, well, as you mentioned to me, look at, guys, it's very important, the last slide. Yeah. As you mentioned to me, that Adam had this injury 4 days ago. Yes. And you brought him today to the hospital. Yes. I can see you are a caring mother, but I can see at the same time you are struggling in looking after Adam, which makes you took some time to bring him. Struggling what? Looking after. Is that judging? No. You see how I'm even telling her? And he's struggling looking after him. And also the story that you gave me about his fracture doesn't really match the injury that he has. And I'm sorry to tell you that I know that you are concerned about him, and we are also concerned about him. And in such situation, we tend to involve a team that is more experienced in such incident. That's why we're gonna refer this to the social services and the stations. Because once I say social services, did you see how I said it? Did you see how I built? Huh? As you mentioned to me, that's at the end. After I made all the steps, admit, keep, investigation, senior, symptomatic, and at a specialist, step 5 is what? Management steps. What's step 5? Specialist. At the specialist, stop. Well, as you mentioned, we will look after 5 days, which I can see that you are struggling in looking after Adam. However, the fact that you give us the story of him falling doesn't really match his injury. So, in these kind of situations, we tend to involve a team who's more experienced than in such conditions, which we call social services. Doctor will be take my son.
I don't know.
Doctor will be take my son.
No.
Are
Are you gonna investigate? I can't tell.
Well, look at my answer, yeah, because that's a question. Well, I totally understand where you're coming from. There is a misunderstanding about social services and taking the children. So usually, we do tend to think that they will take the children from us. However, our main aim is keeping the child with his parent, but in a safe environment. In what? So actually, you are not lying to her. Social services, do they prefer to take the child, or do they prefer actually to leave him with his parent? I'm saying in terms of the child is better to be with his, but they want to make sure he's safe. So the priority is not actually to take him. No, they would prefer for him to be with his, but they want to make sure he is safe. That's the thing. So well, it's not true really. Yes, some people think that social services, once you hear that name, that they take the child. However, our main aim, which means our main concern, the first option, plan A is no, keep him but safe. Plan B is take him. So our main aim, our main concern is to keep him with you, with the parent, however, in a safe environment. Okay? And when I said in the history, when I said in the word history, I said in the history, always ask about the environment. I mean every single person. So if they say to you, my boyfriend is with me, make sure you ask, is he the biological father? How is the relationship between him and Adam? Any stressors in his life? Does he work? Does he manage financially? Because I want to find the stressors in every single person in the house. When I said environment and the stressors, something that will stress me out, so I can get angry and I can get it out in the chat. Okay. Patient requesting something. Patient requesting something. If a patient, guys, and this is a scenario, guys, it is a scenario. Give us an example. Patient requesting specific antigen, patient requesting a CT scan, patient requesting, CA125, patient requesting all plenty of cases. A patient requesting something. How to approach? How can I help you, doctor? I need prosthetic specific antigen. Have you heard about this before? Yes, very common. How to approach a patient requesting something? Number one, why? Well, doctor, because I'm worried in case I'm having prostate cancer. I'm worried in case I'm having what? Definitely, we can help you with this. However, sorry, after cancer, ask why. So I want to be say why cancer. Why you think of cancer? Because my father had cancer. That's the approach. Then you will right away say to them, well, definitely we can help you with that. Yes, we can do it. But it's alright to have a chat to see if you really need it or not. That's the start. That's the first two things. Okay. Can I acknowledge here? Yes, acknowledge. What do I mean by acknowledge? Okay. I will say me and do the same phrases. Same phrase. You want PCA. May I ask why, Karim, you want PCA?
I'm afraid I might have a cancer.
All right. Can you please tell? Don't say sorry, yeah? Because sorry, I understand. Not yet. May I ask why you're thinking of cancer?
Because I just had a friend of mine who died.
Friend of mine, father, mother, huh? Any cause? Oh, I see. Okay. Now I understand why you're thinking of this test. All right. So it's okay to have a chat, okay, in order to see if you're needed or not. If it is indicated, I can assure you will definitely do it. So what is the acknowledgement? What was the acknowledgement here?
When I say that.
When he said my dad, when he said, oh, I see now. What are you thinking of? Yeah, I see. It's acknowledging the importance of his concern. أنت مش عبيط. You are not stupid. You are not crazy. Yeah, you have a valid concern. That's the acknowledgement. Then you start taking history of what? And the history, give me one word.
Yeah.
Relevant history. So, prostate. What is my history? Renal pus in urine. Any problem pus in urine. Weak stream. Dribbling. Hesitancy. Frequency. Plus flows back pain. Family history done. What's the meaning of done? Huh?
No more.
Don't take history about other no. What is his main concern? So my question should be only to say yes or no for prostate, nothing else. Shabab, I have give you some advice today as I was going along about communication skills and cutting things short. I don't know if you got the message or not, or you're tired and I'm talking now and you're not absorbing. And how to calm the patient down and how to make him think, yeah, wow, your concern is very valid. You understand? Yes, I can see. Things like this, I don't know if it was too much today or not. I'm nearly finished. Like half an hour, 20 minutes. I'm nearly finished, but I'm saying, I hope you got the whole message of how to get these things right. I hope you got the message of alcohol and smoking and drugs and exercise and diet and how to approach him and talk about his habit in a way that he will accept and in a way that will be relevant to him. Okay. So a patient is requesting something. Ask why. He gives you concern. Acknowledge the importance of his concern. Yes. You are not stupid. You are not silly. You have a valid concern. Then start take relevant questions, and the relevant question will be related to his problem. Please do not take history, Dr. Hamid. Please do not take history. How is your diet in a patient who wants PCA? Okay. Please, a patient who's coming with blood in urine. With what? Presenting complaint is, please do not ask diet. Can you ask diet in this case? Yes, you can. Yes, you can. This is a trick. Yes, you can. Okay, but you cannot ask exercise. Can you ask exercise?
Yes.
Yes, you can. Because vigorous exercise can lead to blood in urine. Yes. So my point is, go back to PCA. I was just saying, can you ask now? Because he said no, and he's given an example for no, but no. In blood in urine, you ask diet, you ask exercise. Yeah. Anyway, so that's reasons. Yeah. Vigorous exercise can lead to blood in urine, and diet as well. Some, plant and some food can lead to, the urine being. Anyway, so coming back, please always, in a case of patient requesting PCA, Dr. Omar, he's requesting PCA. Why? Cancer and family. Okay?
I can see where you come from. Is it okay for have a chat? And reassure him. Is it okay for have a chat? And definitely, if it is indicated, we will. Then you start. Which history? Prostate history. Okay. In management of a patient who is requesting, how to manage? Patient requesting CT scan. Why? Because I have headache. I'm suspecting a brain tumor. Take history. No brain. Acknowledge first. You know, acknowledge and yes, and then history. No brain tumor. How to manage?
As you told.
Huh? Yeah.
As you told.
Yeah, reason. Well, Mr. Anthony, you mentioned to me early on that your main concern was CT scan. Yes, doctor. Usually, we tend to do CT scan if we're suspecting a brain tumor. Symptoms for brain tumor is usually early morning headache, early morning vomiting, and weight loss. So from the history, you did not seem to have these symptoms. So we don't really think it's not that there is no scan. I said we don't really think that a scan would help you here. Did I say no? There is no scan? Well, how did I say it? I don't think that a scan would help in the situation. And then some doctors will say, because of the X-rays, because of the radiation, don't say it until he said to you, no, I need it. Then you can say, escalate to the next step, risk benefit. Then you can say, well, do you know what will happen if we do scans unnecessarily? But some doctors, they just say all together. Well, I'm really sorry that you're not going to be able to do a scan because the scan is not indicated. And you know what? And even has very bad radiation. Wait, scan is not indicated. Wait. Okay, yes, doctor, all right. But if he said no, then say something else. Don't say altogether. So I really don't think that scan is needed here, is indicated here, because from the history that you've told me, we usually do CT scan if the patient is complaining with one. To give him a reason, please. Okay. Okay. Always think of alternative. Alternative. You remember when I said to the embarrassed ward, I said to him, Ward, would you like me to get you a male partner? But by the way, if you are a male, you cannot offer this, yeah? If you are a male, talk to a male, okay? Don't say to him, can I get you a male partner? Please, I don't want to be confused. Or if you are a female, talking to a female, don't say, would you like me to get you a female partner, a female doctor? No, this is, if it's a different gender that maybe this patient will be able to open. Always think of alternative. Well, I spoke to Mr. Andrew and I said to him, Dr. Omar, the indication of a scan is not having it. Yeah, brother. Radiation is not happy. Yeah, brother.
You don't want to wait.
Sorry?
Some confused, you don't want to wait.
I've given him all the options. Dr. Malek. I'm focused to say the proper, yeah, because she gets, my name is not Malek, my name is Malek. صح كده. Dr. Malek. Alternative means, no, alternative means, all right. What about me speaking to the radiology department? Or what about me speaking to the specific department? Or what about me speaking to, or what about us giving you painkiller? And if you do develop these symptoms that we spoke about, or if you even do feel any of these symptoms, yes, we can definitely think of it. What do you think? That's an alternative. Alternative, يعني in Arabic, حل بديل يعني. Something else. Yeah, he's not gonna come and go and alternative. So they always think of alternative. Always think of something else you can do as a middle stage before this CT scan. So what do you think of giving you a painkiller? Then you can go home and you look out for these symptoms. Hopefully, you're not gonna have it. But if you do, don't say to him, look out for this. If you come away and show him excitement. If you have in the morning headache, that's not, like, because you don't want him to have it. Or what about if I speak to my senior? Or what about if you can speak to an alternative, Dr. Kareem? Okay. Okay. Now, last type of cases, things I've mentioned as well, some of them, but just to remind you. Psychiatric cases. Psychiatric case. If I'm asking, we have in psychiatric cases, we have hallucination, we have depression, low mood, suicide. If I'm asking a patient, first of all, psychotic patient, if a patient is psychotic, do I admit him or not?
Yes.
What if he doesn't want? Huh? He doesn't have mental capacity. فبرضه دلعه برضه ما كنتش انت تدلعني هدلعني حكيم يقول لك دلعني. No, but why? Still he deserved يعني admit him. No mental capacity, admit him. No. Still, why? Maybe he has a concern. يعني هو the end stage you're gonna admit him. You should know this. Psychotic, هو admission. But at the same time, he deserves some some kindness. He deserves. Why? Well, doctor, because I have a dog at home. Why? And then when you address his concern and he's not convinced, that he's gonna be admitted. He's gonna be admitted anyway. We know that, but still he deserves. Why? Address the concern. You understand?
Yes.
So
What if it's a phone consultation? How are we going to tell him?
come to the hospital.
What if he refuses?
If he's gonna send the ambulance, he's gonna be brought. This guy must be admitted. Psychotic patient, there is no way a psychotic patient will not be admitted. So, ask about support. Who's at home with him? Who's at home? You need to know who's at home, yeah? Because maybe you can advise him to come with his wife, girlfriend, as a support, someone to bring him. Yeah, but psychotic patient guys must be admitted. Okay? Anyway, so we have hallucinations. Today I'm telling you how to talk, how to ask. How will you give the question and not offensive? Okay. In a psychiatry station, we ask about hallucinations. In psychiatry stations, we ask about low mood. Okay, if I'm asking a patient about hallucination, visual hallucination or tactile, or he feels something, he sees something, how to ask? Say it.
Some people might see and hear or feel something that others don't feel or see.
Yes. You experience the same thing. Have you experienced the same thing? So always in hallucination, use the third person. So you can say to him, signpost, before all these questions, I'd like to ask you some questions that may sound strange. I'd like to ask you some questions that may sound silly. But usually when we have patients who are complaining of things that they see or hear, we tend to ask them these questions. Would that be right? So I'm giving him sign. I would like to ask some questions that may sound strange as well as silly. Strange. So I know they are strange because you're gonna ask him, can you see things? Can you see things walking in the ceiling? Understand? So it's strange. So signpost it. So I'm gonna signpost. I'd like to ask some questions that might sound strange. Or some people, when they go to difficult time, they can see, they can hear things, they can feel things, they experience the same thing. Hallucination. Please use a third person. Suicide. How to ask about suicide?
people who have access alone would not tend to harm themselves or harm others.
Well, Andrew, from what you've told me, I can see that you are going through so much stress in your life. That's obviously, that's from the history you've taken. You said to you, my dad died and my mom and this and that. So then, well, Andrew, from the history you've given me, I could see that you are going through so much stress and pressure in your life. Andrew, sometimes when people go through so much stress like this, they tend to hurt themselves or hurt others. Have you had such talks before? Third person. Use this trick. Now, how to ask about insight.
Do you think we need our help?
Okay.
The patient is coming with his own.
You think you have a problem?
You talking to him. You can say to him, are you aware of what's happening? Are you aware of what's going on? That's an insight. Yes, I am aware. No, doctor, there's nothing. Are you aware? Are you aware of your condition? Are you aware of what's happening here? Well, do you think you need help from us? Yeah. So that means that, does he know he's got a problem or not? So, are you aware of what's happening? Are you aware of what's going on? Do you think that you will need our help? So, don't ask, do you think you have a problem? Okay.
So if the patient is.
I said it, but don't. I said it before, but don't. It sounds better to say, do you think, are you aware of what's happening? No, because do you think you have a problem? No, I don't have a problem. So make it like more even nicer. Are you aware of what's happening? Are you aware of your condition? Do you think that you have a medical condition that needs to be solved? Or do you think that you will need our help? Do you think that you need our treatment? You know, it's more nicer. Yes, so it's almost to.
Even if the patient is coming like he want to quit heroin.
Oh, that's different. No. The question said a patient is coming and he's being referred to the GP because he went to the GP because he want to quit. And I said to him, are you aware of what's happening? Hi, brother. Welcome. Thank you for coming to see us. You know, that's so nice of you. It takes so much to come here, you know. It's a brave from you, you know. You cannot say, are you aware?
So you can say that you think that you have a medical condition that needs our.
Yeah, but here is no medical, here is mental. So do you think you have a mental condition?
That needs our treatment.
Yes. Or do you think you need our help? Or do you think that you are aware of what's happening? Or do you think, you know, make it nice. So that means insight. Because if he said, no, I don't think that I need your help, no, I don't think that I need treatment, no, that's how to ask about insight. And how to, is insight important?
Yes.
Guys, insight. There is an insight, the patient knows what's happening, he needs the help. If you think that's a good insight, that's good. There's no insight, that's not good. If you ask about insight, if you ask about hallucination, if you ask about anything, always third person, always. And signpost. Okay? And you can even signpost in a nice way of symptoms. I've told you this throughout the whole day now. I said the best signpost now is to signpost by using that symptoms and the symptoms. Well, Mr. Andrew, sometimes when we have patients who are very low, or sometimes when we have patients who are complaining that they can see things or they can feel things, well, we tend to ask them some questions that may sound strange, but it may lead to us reaching the diagnosis. Would that be right? Then start asking me that strange question, because now we know the strange question. So always related to symptoms. Understand? Like how we do section history. When we have a patient who's discharged and this and that, we ask some questions about the style. You're right. So yes, whenever you're talking about alcohol and drugs in a psychiatric station, when a patient is taken, we made the relation. Stressor can lead to mania, yeah? So a patient who's stressed, someone who's stressed, a parent stressed, can abuse the children, yeah? And at the same time, someone, if he's stressed, can he smoke and drink alcohol, too much alcohol and smoke a lot and take drugs? Yeah, so always when you ask about them, you know, in psychiatric history, we ask about alcohol and heroin and drugs, and we do or not? We do. So how to ask? Well, Andrew, Sometimes when people go through difficult times, through tough times, they tend to take alcohol in excess, as well as they tend to take drugs. So it's okay for a chat. Yes. Do you take alcohol? Do you take drugs? So again, I signpost of, I'm not just asking, I'm asking because we're impressed. You go there. So go there. Guys, clear. Very important, Allah, because if you ask in a bad way, especially the psychiatric patient and this patient, and if you got an angry patient, the patient is complaining, if you don't approach well, if you don't acknowledge and you don't just like accept it with them, you are right, you are right, yes, this is right, yes, I was feel the same, yes, I'm here to move forward, yes, I will say, you know, he's not gonna be happy. So it's not a station of, that's why people say, lab 2, you could study a lot and you don't make it. Seriously. Like today, what was done today? Is it really studying? No. Some of you might have this by nature. Some of you might say, brother, what are you talking about? Because for me, it made sense after lab. These things make sense, seriously, after lab. So after lab, you say, oh my God, I needed someone to teach you. If someone is angry, to acknowledge his anger and to say to him, why are you upset? And yes, you are right. You are totally. I needed someone to tell me this. I do it. You know, if someone is quite naughty, he knows how to do it. Yeah, you have the right. You know, back home with my wife when she's upset. Well, I mean, you totally have the right. I'm ready. So you don't come home and you always go to the academy. Well, I totally understand. I'm sorry. You are very supportive. I'm so sorry. And then she looks at me like, it's out of the control. She's like, she cannot be rude. She cannot be, horrible about it. But at the same time, you put her in a situation she cannot do anything. So basically, it's, if you use your nature, it's in all our nature. If your friend is upset from you and they say to you, did something wrong, and they really appreciate your friend, say, oh, I'm sorry. You totally right. I don't know how I did it. I really don't know. I'm really sorry. You have the right to be upset. Please accept my apology. That's what I always say. And I have the right. Accept my apology. I don't know how I did it. If I was you, I will be. That's all the things that we're talking about. Anyway, so what is the most important structure in managing psychiatric patient? What is the most important thing? Yeah, I mean, what will we use? Support. If you go to a psychiatric station without using support, you're not going to pass. If you go to psychiatric station without using, I will tell you now. So if you go and say, well, I will give you methadone, and I will give you this, and I will give you metoclopramide, and if you vomit, and I'll give you painkiller if you, and I will, no, support. The heroin addict needs support at home, needs support from friends, needs support from you, needs support from groups. You remember, I said support in one of the cases, previous cases. I said how many supports? You, people at home, relative and friends, psychiatrists. See, the support will start with me. If you ever need anything, you can come to us. People around you, you will need their support. In heroin addict, does he need support from family? Okay. IV drug abuse and people who are alcoholic, people who are on drugs, and people, do they really need support from relatives and friends? Yes. Yes, guys. So please, Dr. Hamid, in a psychiatric problem, don't ever forget that 50% of the management is depending on the support, starting by you, saying to him at any time, you are welcome. Who's at home? Your wife, your girlfriend, your relative. You need his support. If you feel low, you can talk to them. If you feel the urge, the need to talk, you can ring them. You can ring us. And finally, support groups and psychiatry. So support system, starting by you in the clinic, people at home, friends around him, support to use the psychiatry. Don't forget. Plus the drugs that we all know. Okay. That's it. Remove the fish. Yeah. Guys, I hope that made sense today. I hope that today, like, you gained anything. You know, today if we gain. So let's switch off this.